First class not, the lunch coupon is available there. So if you want lunch, you can take lunch coupon from outside. The other hall is ready actually. If you find it will be crowded here, you can shift to other hall. Some of you can shift to other hall. Yes, so good morning to all of you. So nice to be in Kozhikode. So for 4 days we will be having sessions in pharmacology. So tell me, how much do you like pharmacology? How many of you like pharmacology? Very few. Why? Why? Only one or two. Why? So as far as sentence is concerned, as far as anything is concerned, how important pharmacology is, everyone knows. The moment you start writing a prescription, there starts pharmacology. And the last thing that you stop writing when you retire will be with pharmacology. Two, as far as sentence is concerned, 25 questions surely you will get from pharmacology. Correct? Correct? Plus 15 questions from other subjects. That contributes to 40 questions. Plus 45 questions in medicine, plus 15 questions in physiology will give you 1/3 of entrance. So the problem with these three subjects are that they are very, very, very delicate, not at all edible. Okay, and among these three, the most toughest naturally is pharmacology. So P. Rao sir will be teaching you surgery. When he teaches you surgery, he will teach you as far as sentence is concerned, the most important subject, that is pharmacology. So, why you did not? Yes, no, so the students are confused. The thing is, I have not got my promotion orders. So next month probably I will get my promotion orders. Till that I must still. Yes. So probably next month I will be associate. So, as far as pharmacology is concerned, the most important problem with pharmacology is that we don't know. We don't know from where questions will come from. One. Two. Even the questions come from, we are not sure whether it will be from Harrison, Goodman, Katzman. Clearly? Yes, clear? But surely not from KDT. So that is the first thing. Two, even the latest edition of Goodman and Gilman is an outdated edition. It has only been updated till 2007. The latest edition, 12th edition. If you look at the antibiotics, the latest drug that has come is Ritabamulin. 2007. Heard about tigecycline? Daptomycin? Are they new drugs? They are old drugs. They have become old drugs. The newer drugs are 2007 Ritabamulin has come, 2007 Pelavancin has come, 2009, 2010 Ceftaroline, the first drug which acts on penicillin protein 2A, or the first cephalosporin, or we called as advanced generation cephalosporins. In 2011 case, ridaxomycin. So not a lot of things are coming in. Questions that can be asked from anywhere. Questions can be asked from anywhere. Denosumab was asked in 2007. It was approved only in 2010 June. As far as monoclonal antibodies are there, how many of monoclonal antibodies? 28. Even they are asking not only the names but also the trade names. Instead of trastuzumab, they ask Herceptin. But absolutely we don't know from where it will come from. That is the greatest thing with pharmacology. For example, if you take physiology, surely Garen. Community medicine, nothing other than Park. Clear? Surgery, Bailey. But we don't know the subject. 2. Never ever touch capsule. Capsule looks like a small book. It looks like a small book. You may think that you understood it, but surely what you understood will be surely wrong. First point. 2. Never ever look at Goodman and Gilman. It is so tough for you to understand. If you ever look at it, you will get a PhD in pharmacology. That means passed with very high difficulty. Is that clear? So what you do is, you study whatever drugs, whatever things that you have studied for your MBBS, whether it is Sadoskar, Kirloskar, KDT, DDT, whatever it is, plus add on the concepts that I give to you, plus the previous questions. That's how you study. My notes will cover most of the concepts from Harrison, Goodman and Casper. Is that clear? This much clear? Fine. So, till now you have been, see, every day is a pharmacology. Every day whatever happens in everyone's life, pharmacology will be there. So 3 days back, so I thought of having a anti-dandruff shampoo. So Nizzarol, I had a ketoconazole. Within seconds, I done a severe redness of face, everything burned up. Immediately I had to rush to, you can see over here, all full allergic. And I had to rush over to the medical store, buy hydrocortisone, applied immediately. So every day is pharmacology. Clear? As far as the doctor is concerned. Now, till now what you have been doing was learning pharmacology by heart. Very correct? Correct? Absolutely, it is not possible. So the greatest foolish thing that you have been doing. 2. From now onwards, after hearing my class, you will be starting to understand pharmacology. What it will be, you will find it later. Clear? 2. The problem with pharmacology is that it has a very short half-life. It classically is eliminated from the body by first-order kinetics. The more you study, plasma conservation rises, more elimination will be there. The moment you understand it, its kinetics changes from first order to zero order. So whatever you study, it becomes a toxic dose and in the 6 years. So that is how pharmacology is. Is that clear? Not a lot of things with Goodman. So for example, let me tell you something about Goodman and then we start. Goodman and Gilman, as you all know, all India aims, most of the concepts are from Goodman. PGM, JIPMA, they are from capsule. Kerala also, they concentrate sometimes mainly on capsule. But whatever it is, the concepts are the same. In 1914, Professor Gilman, a professor of pharmacology from a small university, I don't know whether you are familiar with that, not so standard, called as John Hopkins. Yes. He studied sort of idea book and was associated with his friend Goodman, who was from the Yale University. The first edition of Goodman and Gilman came out in the year 1945. Yeah? Which is widely regarded as the utmost book in pharmacology now. In 1945, a son was born to Gilman, whom he named Alfred. Yeah? Whom he named Alfred. Now, because the book was launched on the same year Alfred was born, Alfred was given the surname of a book. Goodman Gilman. Okay? Alfred grew up to continue his father's legacy and was the one person to get the Nobel Prize. So like father, like son, to discover one of the most important things that you always study but you don't know. What is that? Any idea? For which he got the Nobel Prize? G proteins. The G proteins were discovered by Alfred. And he went on to edit his father's book till the 11th edition. Okay? For the 9th edition onwards, he started editing the book. So Alfred Goodman Gilman is not that father, son and father's friend writing a book. Alfred Goodman Gilman is a single author. Last year he stopped writing the book and his friend now Brenton is editing the book. That's about Goodman and Gilman and Alfred. There are two areas where I commonly ask you the historical aspects. One is autonomic nervous system and second is antibiotics. These are the two areas where I commonly ask you historical aspects. As far as you are concerned, we always know that. Don't write down. We never ask you MCQ. We always studied that. Who discovered that mouse can kill bacteria? Yes? Alexander? Fleming, correct? Correct? Is absolutely wrong. That is what you have studied. Yes or no? No. History says that even though this is true as far as the Britishers are concerned, there is a person called as Ernest Deschney who made this discovery around 32 years even before Alexander Fleming discovered penicillins. Yeah? He did this discovery when he was a second year student, postgraduate student in Louis Pasteur Institute. That is also not a standard institute, you know that. You know that, yes, very good. He presented for a thesis, but his thesis was unaccepted and disappointed. He had a lot of research works on it. Disappointed, he left the postgraduate study in between, joined the French army and was killed at a very early age of around 38 years. So history says that his theory was not accepted by the Louis Pasteur Institute because he was only 23 when he proposed the theory. So long after he died, around 15 years later, after Alexander Fleming got the Nobel Prize, he was posthumously honored by the Louis Pasteur Institute. Yes, he is not recognized, but he is the only person who is honored that mouse can kill bacteria. There are four questions that are commonly asked in MCQs. One, there was a Boxman. There was an Ukrainian-born American who discovered the first amino glycoside, streptomycin. Mercury discovered one of the deadliest drugs ever discovered, but which turned out or which paved way for the discovery of one of the most magnificent of all drugs, which one? Azithromycin. So he discovered erythromycin. Professor Bosu discovered the first cephalosporin. Mercury, erythromycin. Mercury discovered erythromycin, which paved way for discovery of azithromycin. Professor Bosu. He was the one person who was supposed to be given the Nobel Prize, but was not given the Nobel Prize, right? Was not given the Nobel Prize, right? Was not given the Nobel Prize, right? Reasons because he was an Italian and a close friend of Napoleon. That's the only reason why he was not given the Nobel Prize. Two, Dweck was a German who discovered photocell. discovered fluorosil, the first sulfonamide. Immediately after announcing the Nobel Prize for the month, the Nazi army stepped into his house, took him, put him under house arrest. The reason was only, what was the reason? Any idea? Simple, because Hitler did not like Nobel Prize. And he was put here, simple. He was put under house arrest and was not released till the end of Second World War. After the end of Second World War, he went on to collect his Nobel Prize, but he could collect the Nobel Prize, but not the money, because the money has to be collected within 1 year. So the money lapsed away, but he got the Nobel Prize. That's the historical aspects as far as the drugs are concerned. Bacteria, I will not be teaching you microbiology. 1. Staphylococcus, Streptococcus, Enterococci. Correct? As far as sentence is concerned, Enterococci are the most common questions asked in examination. 1. Can you tell me any peculiar feature of Enterococci? Yes? They are the most common causes of? Yes? Urinary tract infections. What is the main problem? None of the Enterococci, none of the cephalosporins are effective against Enterococci. There is a previous question for you. None of them. 2. None of the sulfonamides are effective against Enterococci. Why? Because Enterococci is that organism which uses exogenous folate similar to humans. Similar to eukaryotes, they utilize exogenous folate. They don't make their own folic acid from pharma. And 3, Enterococci is the one who is notorious for producing the VAN8 gene, which confers resistance to vancomycin. Then on the gram-positive bacilli, you have aerobes, bacillus, listeria, and anaerobes, clostridium. If I ask you a question, a previous question for you, is penicillin G effective against anaerobes? Is penicillin G effective against anaerobes? No. Answer is wrong. It is effective. That's the reason why you can use it against Clostridium tetani. But if I ask you a question, which is a drug of choice, is it metronidazole or whether it is penicillin G, penicillins which are the drugs of choice in tetanus, then what will be the answer? Penicillin G is wrong. We use penicillin G over here, but it is for prophylaxis. In a patient diagnosed with tetanus, the drug of choice now is metronidazole. Why? Why? Because penicillins have GABA antagonism. What is the problem in tetanus? What is the main problem? Spasm, correct? Because of inhibition of GABA. Penicillins have GABA antagonism. So they may increase the seizures. Listeria was a drug of choice? Yes? Is it ampicillin or amoxicillin? It is ampicillin. Remember that none of the other drugs like amoxicillin are not effective in listeria. Next, none of the cephalosporins are effective against listeria. Clostridium, which are the types of Clostridium of Clostridium, tetani fine, Clostridium, difficile fine, Clostridium, Burfinger's fine, then botulinum. Can you tell me what is the drug which is most effective against? Tell me the drug that is most effective against Clostridium perfringens, or older name Clostridium melchi. Yes, which one? The most effective drug. It is cleaning clindamycin. Why? Because clindamycin is the one antibiotic that poses inhibition of toxin production in bacteria. It can inhibit production of toxins in bacteria. Clindamycin. Now if I ask you a question, which is the drug that causes maximum incidence of, which is the bacteria, which is the antibiotic that is the most associated with pseudomembranous colitis? Clarithromycin is wrong. It is clindamycin. Then if I ask you a SGBJ question for you, from that I will ask you SGBJ question. Which of the following is not associated with pseudomembranous colitis? 1. Clindamycin. 2. Doxycycline. 3. minocycline. And 4. gentamicin. Which of the following is not effective against, which of the following does not cause pseudomembranous colitis? Doxycycline, clindamycin, gentamicin, or one more which one? Minocycline, fine. Which one? Why gentamicin? Why? Not that because it is given rapidly. Any idea? The spectrum, what is the spectrum of gentamicin? Fine. Is it effective against anaerobes? Is it effective against anaerobes? No. As a classical feature of aminoglycosides, not effective against anaerobes. In the GIT, there is an antagonism. In the GIT, there is an antagonism between the growth of Clostridium difficile and Bacteroides fragilis. Always Bacteroides fragilis is a normal commensal, correct? It will inhibit the growth of Clostridium difficile. So whichever drug will kill Bacteroides fragilis will have high incidence of producing pseudomembranous colitis. Classical example is clindamycin, which is very active against Bacteroides fragilis. Whichever does not kill Bacteroides fragilis will never cause pseudomembranous colitis. Classically, aminoglycosides, because it is not effective against anaerobes. Is this much clear? Yes, very clear? Neisseria, Moraxella, gram-negative bacteria, you have aerobes, Enterobacteriaceae, Pseudomonas, H. influenzae, and anaerobes. So, Bacteroides fragilis is a gram-negative anaerobe, while Clostridium difficile is a gram-positive anaerobe. This was clear? Yes? Astriona. Monobactam. What does that mean? Mono means single ring. Bactam means, it is not beta-lactamase, it is bacteria. Astrionum is the only monobactam in use. Can anyone tell me the spectrum of Astrionum? Gram-negative, gram-positive. Anaerobe. Examination, yes, tell me the spectrum. Staphylococcus, streptococcus, enterococcus, ഇങ്ങനെ അവസാനം ഇത് ബാക്ടീരിയ സജീവനം നിർത്തും. കറക്റ്റ്? കറക്റ്റ്? Wrong. The spectrum of astrionam A equals to A aminoglycoside. That means it is effective only against gram-negative bacteria. And both these A are not effective against the third A, anaerobes. Anaerobes. Is that clear? Third A, anaerobes. Astrionam is used as a alternative to aminoglycoside. In a patient with renal failure, just give me the book. In a patient with renal failure, and in a patient with renal failure and in a patient who is pregnant. Aminoglycosides, actinomycetes, griseofulvin from penicillium griseofulvin. Quinolones are entirely synthetic. Quinolones are entirely synthetic. So take your questions, answer the questions from 1 to 9. Let us see how much you will answer, and after knowing the concepts you will understand how much you are wrong. From 1 to 9. Yes, could you answer? How many of you could answer this? Full ആർക്കൊക്കെ ആൻസർ ചെയ്യാൻ പറ്റി? ആൻസർ ശരിയാണോ എന്നറിയില്ല. Okay, fine. Now we can understand, after understanding the concept, we can see how much you will be able to answer. 1. Clear? This much is clear? Mono, lactam. Types of action of antimicrobial agents. 1. Drugs can act on cell wall. Drugs acting on cell wall are comparatively safer to us. Why? Yes. Why? Why drugs acting on cell wall are comparatively very safe to us? We don't have any cell wall. 2. Those acting on cell membrane. 3. Drugs can act on protein synthesis. 4. Nucleic acids. And 5. Antimetabolites. And 5. Antimetabolites. Antimetabolites. Clear? Now first one, cell wall. Beta-lactam compounds. They are called as beta-lactam compounds because they have a beta-lactam ring. I don't know if you know that. The classical one that has a single ring is monobactam. So what is the classical feature of this monobactam? The side chain, it does not have a side chain, correct? Correct? Unlike the others, it does not have a side chain. It has only a monobactam, that is mono, single ring. The others have side chain. That is the reason why they do not have any cross allergy with penicillins. It can be used safely in a patient with penicillin allergy. Can you tell me the drug that has the highest incidence of cross allergy? Cephalosporins. Wrong. It is carbapenems. They have 50% cross allergy. They have 50% cross allergy. Is much clear? Astrionam does not have any cross allergy with any of the beta-lactam antibiotics with the exception of dash. That drug turns out to be the drug of choice in Pseudomonas. So if a patient is allergic to that drug, you cannot use Astrionam also, which is very efficient in Pseudomonas. Which is that drug? Ceftazidime. It has only cross allergy with ceftazidime because of similarity in structure. Others are vancomycin and teicoplanin. Vancomycin, where is it classically used? Yes, as the name implicates, it is used to vanquish MRSA. What is the difference between teicoplanin and vancomycin? That's all the most important thing. Vancomycin cannot be given IM. It produces tissue necrosis, while teicoplanin can be given IM. In addition, teicoplanin has a longer half-life, but it is not FDA approved. Vancomycin is a glycopeptide. Previous question for you. Daptomycin, a new drug that has been approved for MRSA, daptomycin. Do not confuse it with dactinomycin. Dactinomycin is different. Daptomycin. Is that clear? Daptomycin. Daptomycin is a lipopeptide. While felavancin is a lipoglycopeptide. Approved in 2009 for MRSA. Felavancin is a lipoglycopeptide. Lipoglycopeptide. Cycloserine. In the MCQs, do not confuse, multiple times they confuse you. Do not confuse between cycloserine, cyclosporine. 2. Buspirone, bupropion. 3. Amiodarone, amrinone. 4. Drotacogen alpha, darbepoetin alpha. 5. Disopyramide, dipyridamole. These are the 5 things that they commonly confuse you. Among this, the most commonly they ask for confusion is cycloserine, cyclosporine, disopyramide, dipyridamole. Disopyramide, dipyridamole. 3. Buspirone, bupropion. 3. Buspirone, bupropion. 4. Amiodarone, amrinone. And 5. Drotacogen alpha, which is a recombinant protein C, and darbepoetin alpha, which is a recombinant erythropoietin. Darbepoetin alpha. Drotacogen alpha is used where? Yes? In septic shock. Protein is a recombinant protein C. Cycloserine, is it an antibiotic? Is it a peptide antibiotic? Yes. 2. Cyclosporine, is it a peptide antibiotic? No, wrong. It is also a peptide antibiotic. Cyclosporine is also a peptide antibiotic. Bacillin. As the name implicates, bacilli obtained from bacteria. Correct? Tracing means what? That bacteria you obtained from a 7-year-old girl, Tracy, named Tracy. That is why bacillin. Is that clear? That's how the name came. Obtained from bacteria, which is obtained from Tracy. The classical spectrum of bacillin, it is a polypeptide antibiotic. A very frequently asked PG question for you. It is a polypeptide antibiotic and is extremely nephrotoxic. It is never used for parenteral use. Am I fast? No. Is that clear? When you use a book വായിക്കുമ്പോൾ ഒരു കാര്യം ശ്രദ്ധിക്കേണ്ട കാര്യമുണ്ട്. എന്താണെന്നറിയാം? When you use a book, the most important thing is you should first understand. Do you understand that book? What is written in that book? കുറച്ച് അല്ലേ? Yes. As in later stages you will understand that എഴുതിയാൽ അതേപോലെ കോപ്പി വെച്ചിട്ടുള്ളത്. കാരണം first thing is don't read any books before hearing my lecture. Clear? Actually that book came out in 2007 after my first lecture in Calcutta. Exactly duplicate printout I could teach you. Clear? And how is that? It thing, concept which cannot be taught by too many of people, pharmacologists, can be written by a pathologist. Is a wonderful thing to think about. Yes. So first you understand my notes. And also ultimately മനസ്സിലാവും whatever is in that book can only be explained by me. Clear? And after that read the note. That is trusting. That is trusting. 2. It's a fusion of two notes. One was mine plus the fusion of Gilly Ma'am's notes long before she died, long back. The fusion of these two notes. But the problem is that the moment we put a question, or I put a question, immediately it will come in that book. Exact questions, it exactly put it. And after 2010 I stopped putting questions. Karam, and then they take a copyright. So why to put a question? After that I thought about only teaching the concepts. Now since they don't have anything to add on, now what they are going on adding is, they are going on adding all year's question paper. Because none of my questions are coming out. So every year they are going on adding all state level question papers. So what happens is, after a long period of time, or probably 2 to 3 years, it will overtake Goodman, Gilman. And level is region. Clear? Do you understand? We don't read guide. That's the point. Guide is vaayikkaruthu. Do you understand? Karanam, you have a habit of reading textbook. Textbook is each and every concept 916 I will be teaching you. Because I know what is there. But he does not know what I am supposed to teach. And he has honored me by giving my name. Dr. Sunil has prescribed. There is a question number. So read your book. ഏത് ബുക്കാണോ പഠിച്ചിട്ടുള്ളത് അത് പഠിക്കുക. ആദ്യം ഒരു ഗൈഡ് എടുത്ത് വായിക്കേണ്ട ശീലം എളുപ്പത്തിൽ കിട്ടുന്നുള്ളത് മാറ്റിവെക്കുക. The best book to study cardiovascular pharmacology and antibiotics is none other than Harrison. ഈ രണ്ടിലുമാണ് pharmacology കിടക്കുന്നത്. So you have a habit of reading text. Plus, ആ ടെക്സ്റ്റ് അതിൻ്റെ ചുമ്മാ ഒരു ബുക്ക് എടുത്ത് വെച്ചിട്ട് അതിനകത്ത് കുറെ ഇമ്പോർട്ടൻറ്റ് പോയിന്റ്സിൽ കാര്യമില്ല. ഹൗ മച്ച് പോയിന്റ്സ് ക്യാൻ യു റിമെമ്പർ? അതിനകത്ത് എത്ര പോയിന്റ്സ് റിമെമ്പർ ചെയ്യാൻ പറ്റും? ബട്ട് യു ക്യാൻ റിമെമ്പർ ദി കൺസെപ്റ്റ്. The eyes will see what the mind knows. Once your mind knows that, അല്ലെങ്കിൽ ഇതെല്ലാം പഠിക്കുന്നത് മുഴുവൻ കാണാപ്പുറം പഠിക്കുന്നത് ഇപ്പോൾ ക്യാമറയിൽ എടുക്കും. ഒരു 5 ഹാഫ് ലൈൻ മുമ്പ് എല്ലാം പോകും. The moment you understand the concept, it goes to your neocortex. It retains there. Whenever you want, you can use it. So have a habit of understanding the concepts and then writing it. Is that clear? Clear. The textbook ആണ്. Most of the students who qualify get the top rank. You ask them, കാണാപ്പാടം ഗൈഡ് പഠിച്ചുകൊണ്ടല്ല. Guides are necessary, sure. But only after the concepts have been cleared. ആദ്യമേ ഇതെടുത്ത് പഠിക്കരുത്, ഉള്ള ഗൈഡും കൂടെ മാറിക്കിട്ടും. That is trusting. So most of the guides are not written based on, it's just വിറ്റ് രൂപ ഉണ്ടാക്കാൻ വേണ്ടിയാണ് ഗൈഡ്സ് എഴുതുന്നത്. താൽക്കാലികമായിട്ടുള്ളൊരു ആവശ്യത്തിനാണ്. Texts are written for knowledge. Remember that. That's it, Rasil. How many of you have prescribed neosporin powder? Neosporin powder എഴുതി കൊടുത്തിട്ടുണ്ടോ? കൊടുത്തിട്ടുണ്ട്. അതിനകത്ത് എന്താണുള്ളത് നോക്കിയിട്ടുണ്ടോ? പോളിമിക്സിൻ, ന്യൂമൈസിൻ vancomycin, bacillus. Very good. എന്തുകൊണ്ടാണ് ഇങ്ങനെ മൂന്ന് മരുന്ന് കൊടുത്തത്? Broad spectrum. How? നേരെ തിരിച്ചിടും, ഓപ്പോസിറ്റ് ഇടും. പറഞ്ഞ നേരെ ഓപ്പോസിറ്റ് പറയും. ബാസിട്രസിൻ gram positive and polymyxin gram negative only. So both when combined together, you get the spectrum is widened. Two, polymyxins are also never given parenterally, but now they have come back again. Where? Yes, they have come at last line resort. Where? Last line bracket on solved. Multi-drug resistant pseudomonas. We'll teach you later. Phosphomycin. Phosphomycin. As the name suggests, phosphomycin is not a aminoglycoside. Naturally, what is its indication? Its indication is in treatment of UTI in pregnancy. UTI in pregnancy. This was clear? Beta-lactam compounds are 1. Penicillins, cephalosporins, carbapenems, monobactams. If you are asked, tell me the beta-lactam antibiotic with the broadest spectrum. Cephalosporins are wrong. They are carbapenems. When it is a spectrum choice, it is monobactam. Look at this. How many of you have studied this diagram? How many what you have understood? Look, you need a Nagin method. What is this basically? Oh, sure. Lot of questions start from it. You go in a sequential manner. 1. N-acetyl glucosamine is converted to N-acetyl uramic acid with the help of the enzyme phosphoenol pyruvate transferase. With the help of the enzyme phosphoenol pyruvate transferase. N-acetyl uramic acid is combined with 3 molecules of amino acid to form N-acetyl uramic acid tripeptide. N-acetyl uramic acid tripeptide will combine with dala-dala, D-alanine, to form N-acetyl uramic acid pentapeptide. Clear? 1. Tell me about a drug that blocks the enzyme phosphoenol pyruvate transferase. Yes, phosphomycin. 2. Tell me about the drug that blocks the synthesis of dala-dala. Vancomycin, wrong. It is cycloserine. The most important side effect of cycloserine is mainly neurological, which can be mainly or partly reversed by pyridoxine. What is ship? Propanamide. Now next you are supposed to know also CHIP, CHIP, the drug that cause B6 deficiency. അതിനകത്ത് C stands for cycloserine. എപ്പോഴും ചോദിക്കുന്നത് സൈക്ലോസെറിന്റെ പേര് മാറ്റിയിട്ട് സൈക്ലോസ്പോറിൻ ഇടും. H സെയിം, I സെയിം, Hഉം Iയും സെയിം. P stands for penicillamine. Whatever P is propanamide, here P is penicillamine. Yes, shipile it is propanamide. Yes sir. S sulfonamide. IINH. എന്താണ് ഡൗട്ട്? എന്താണ് ഡൗട്ട്? ഡ്രഗ്സ്, ഓ അതാണ് ഡ്രഗ്സ് മെറ്റബോളൈസ് അസറ്റിലേഷൻ, അതാണ് ഷിപ്പ്. One molecule of N-acetylmuramic acid pentapeptide. Chip എന്ന് പറഞ്ഞാൽ those which cause pyridoxine deficiency, B6 deficiency. N-acetylmuramic acid pentapeptide plus one molecule of N-acetylglucosamine, which is a building material, has to be transported outside cell membrane. Correct? Cell wall is outside or inside cell membrane? Outside. It has to be transferred outside. Correct? That is with the help of the carrier protein bactoprenol. And the activity of bactoprenol is blocked by, tell me, bacitracin. Yes, clear? What's your name? Bijoy. Bijoy ഏത് ടെക്സ്റ്റാണ് വായിക്കുന്നത്? പിന്നെ so as I see each other student, I tell you, you're working a lot, you're working hard, but your work is not coordinated. Clear? A lot of time. Have a coordinated approach of understanding. കുറേ വായിക്കുന്നുണ്ട്, പക്ഷേ കോർഡിനേറ്റ് ചെയ്യുന്നില്ല. Yes, bacitracin. Once you coordinate, it can work miracles. Next, the final step is that brings integrity to the cell wall is a transpeptidation reaction. Correct? Is that correct? Correct? Before transpeptidation reaction, two things has to take place. One, a transglycosylation between two glucose molecules, and bactoprenol has so final transpeptidation number. Two things has to occur. One is a transglycosylation reaction has to take place, and second, bactoprenol has to leave the building material. Correct? Thermal മാത്രമേ transpeptidation reaction will occur. Correct? Yes or no? Yes or no? And that is blocked by vancomycin. It blocks transglycosylation and release from carrier protein. The action of vancomycin is by binding to dala-dala. Well, the action of cycloserine is synthesis of dala-dala. മനസ്സിലാവുന്നുണ്ടോ? Vancomycin and ecopladin, both same action. So vancomycin prevents release from bacterphenol and 2 inhibits transglycosylation reaction. Here, the final step, what did I tell you? Transubstitution, which is catalyzed by penicillin binding proteins. Correct? Correct? And the transfiltration reaction is blocked by, tell me, beta-lactam antibiotics, all beta-lactam antibiotics. Is blocked by all beta-lactam antibiotics. When penicillin binding protein come and attach to dala-dala, what happens? Transfiltration reaction occurs. Correct? Correct? The beta-lactam antibiotics will bind to penicillin binding protein so that it cannot bind to dala-dala. മനസ്സിലാവുന്നുണ്ട്? മൂന്നിന് വ്യത്യാസങ്ങളുണ്ടോ? Cycloserine inhibits synthesis. Vancomycin will attach to dala-dala. Beta-lactam antibiotics will inhibit attachment of dala-dala to penicillin binding protein. They will block penicillin binding proteins, thus blocking transfiltration reaction. Those acting on cell membrane. 1. Daptomycin. Daptomycin, as I told you, is a lipopeptide used in MRSA. Listen. Daptomycin, the classical mechanism of action of daptomycin is it causes depolarization of cell membrane. The cell membrane will turn over so that calcium, magnesium, potassium, everything comes inside. Bacteria will undergo seizure and death. It is unique mechanism of action. Unique mechanism of action karanam still resistance has not developed for daptomycin. Bacteria has approached Microsoft for a software to find resistance. But then, vancomycin and daptomycin there's a problem. Daptomycin, one of the greatest problems is it is easily inactivated by surfactant present in the lungs. For systemic infections, it becomes less effective, especially pneumonia. Polymyxins are polymyxin B and polymyxin E. Clear? In polymyxin E are what we call colistin. They went out of use, polymyxins went out of use, B and E. E and colistin. They went out of use because they are polypeptides and also notorious for their nephrotoxicity. They are the last line drugs for multi-drug resistant pseudomonas. much clear? Yes? Important resistance to cell wall inhibitors. Vijay, we developed what? Beta-lactam antibiotics against bacteria, correct? Correct? So what is bacteria do? Beta-lactams, cut the beta-lactam ring. 2. Then what did we do? We put a wall around the beta-lactam. We surrounded the beta-lactam. Correct? With the help of, yes, drugs like methicillin, which we call penicillin-resistant penicillin. These drugs have additional structure covering the beta-lactam ring. That is the reason why they are huge, bulky molecules. That is the reason why their elimination is somewhat different from the classical penicillins, MCQ. They are mainly hepatic. What is the classical mechanism of elimination of penicillins? Penicillins are highly plasma protein bound. So, what is the main mechanism of elimination of drugs that are bound to plasma protein? Tubular secretion. Penicillins are so fast eliminated by tubular secretion that there is no time for metabolism. Previous question. They are so fast eliminated by tubular secretion that there is no time for metabolism. While penicillin-resistant penicillins are classically metabolized, or they have hepatic elimination. Methicillin is no longer used. Why? Interstitial nephritis. Carbenicillin can cause methicillin, cloxacillin, oxacillin. Methicillin, cloxacillin, oxacillin. Nafcillin. Methicillin, cloxacillin, oxacillin, nafcillin. These are the penicillin-resistant penicillins. Nafcillin also is notorious for causing neutropenia. Carbenicillins are anti-pseudomonal. Next. So penicillin-resistant penicillins. So what did we do? So bacteria, what did they do? Our penicillin-resistant penicillin, we covered the beta-lactam ring, correct? So what did bacteria do? Simple, they modified the penicillin binding protein. Seriously, beta-lactam antibiotics will come and attach to penicillin binding protein, correct? Correct. So they produce a new type of penicillin binding protein which we call PBP2A. And this is produced by MECA gene. So, MRSA, MECA gene. And thus was born the superbug MRSA by modification of penicillin binding protein. Our penicillin binding protein is modified none of the beta-lactam antibiotics are effective. Is this much clear? Is this much clear? So, MRSA resistant to methicillin are resistant to all penicillins, all cephalosporins till October 2010, all carbapenems can use monolactams. ഉപയോഗിക്കാം. ഉപയോഗിക്കാം. ചുമ്മാ ഉത്തരം പറയരുത്. Are you from the army? No, very good. I had a student long back, 2008, called Major Rakesh. ചോദ്യം ചോദിക്കേണ്ട ആവശ്യമുള്ളൂ, മേജർ ആൻസർ will be wrong. Ultimately I said, Major, this is not the border that you fire at sight. മനസ്സിലായോ? എന്തുകൊണ്ടാ പറഞ്ഞത് അസ്ട്രിയോനാം എഫക്റ്റീവ് ആണെന്ന്? അതുകൊണ്ടാണ് അസ്ട്രിയോനാം സ്പെക്ട്രം ഗ്രാം നെഗറ്റീവ്. MRSI പിന്നെ എങ്ങനെ ഉപയോഗിക്കും? ഇൻട്രസിൽ അസിസ്റ്റന്റ്. മനസ്സിലായോ? Till October 2010 എന്ന് പറയാൻ കാരണം, in October 2010 FDA approved ceftaroline. And in nomenclature ഇപ്പോൾ confusion ഉണ്ട്. Some people call it as fifth generation cephalosporins. പക്ഷെ ചിലർ some disagree with it and call it as advanced generation cephalosporins. Ceftaroline, CEFTAROLINE. The spectrum resembles vancomycin. The next drug which is in fast track is ceftobiprole. Ceftobiprole. We will approve it. Why? Because it's a Japanese drug. Simple. എത്രയും വേഗം എൻട്രൻസ് എഴുതി എടുക്കുകയാണ് നല്ലത്. മനസ്സിലായോ? ബിക്കോസ് ജപ്പാൻ ഹാസ് എൻറ്റേർഡ്. ജപ്പാൻ എൻട്രി ചെയ്യുമ്പോഴത്തേക്ക് നമുക്ക് ചിന്തിക്കാനുള്ള എന്തൊക്കെ സംഭവിക്കുമെന്ന്. ഇപ്പോൾ അവര് they have stopped all research works on electronics and they are diverting all their money into pharmaceutical research. Nikon, Nippon, Takeda, ഇതെല്ലാം ജാപ്പനീസ് ഇൻഡസ്ട്രീസ് ആണ്. They are all coming with a lot of monoclonal antibodies, lot of drugs. Computer shows PPAR alpha കണ്ടുപിടിക്കും. Where fibrates. അപ്പോ അമേരിക്കൻ CPAR ഗാമ കണ്ടുപിടിക്കും. Where thyroglobulins used in diabetes. അല്ലേ? അപ്പൊ ജാപ്പനീസുകാര് ഡ്യുവൽ PPAR കണ്ടുപിടിക്കും. They are already in phase 3, which can be used in diabetes as well as triglyceridation. Is it clear? So all the drugs are efungumab, nicomycin, ഇതെല്ലാം അവരുടെ മരുന്നുകളാണ്. All coming into the market. Phase 3 എത്തിക്കഴിഞ്ഞവരുടെ. Is that clear? Right. See, ഒരു ഡ്രഗ് നിങ്ങളായി കണ്ടേ പിടിക്കുന്നില്ല. അറ്റ്ലീസ്റ്റ് അതിനെ ശരിക്കും പഠിക്കുകയെങ്കിൽ ചെയ്യും. ഒരു ഡ്രഗ് കണ്ടുപിടിക്കുക എന്ന് പറഞ്ഞാൽ റീസൺ വൈ ദീസ് ഡ്രഗ്സ് ആർ വെരി കോസ്റ്റ്ലി. ക്ലിയർ? നമ്മളിവിടെ ഡ്രഗ് ഇറക്കാറില്ല. വൈ? The last of drugs that came from over here in India is pharmacin. 1960s-70s ഇറങ്ങിയതാണ്. അത് വന്നതോടെ 2 മാസത്തിന് ശേഷം കമ്പനി കൂട്ടി, എന്നേക്കായി കൂട്ടി. പിന്നെ കുറെ വർഷങ്ങൾക്ക് ശേഷം അത് തുറന്നത് ഹിന്ദുസ്ഥാൻ ആന്റിബയോട്ടിക്സ്. exactly ആ സമയത്ത് 3 പേരാണ് കണ്ടുപിടിച്ചത്. ഒന്ന് the Americans first they developed the amphotericin B. Immediately we developed pharmacin. At the same time Americans again developed nystatin. Nystatin എന്ന് പറയാൻ കാരണം ന്യൂയോർക്ക് സ്റ്റേറ്റ് ലബോറട്ടറി എന്നാണ് ആ പേര് കിട്ടിക്കുന്നത്. The cost of one drug to come into a market is in millions and billions. Classical example of drug that came in MCQ but was not approved. Any idea? CETP inhibitor. Which one? Torcetrapib. That is a Kerala entrance social. Torcetrapib. CETP inhibitor, which can increase HDL cholesterol. CETP is a cholesterol ester transfer protein. But it came till phase 3. Phase 3 കഴിഞ്ഞു മാർക്കറ്റിംഗിന് തൊട്ട് മുമ്പ് ഡ്രഗിന്റെ മാർക്കറ്റിംഗ് നിർത്താൻ പറഞ്ഞു. Because severe hypertension was seen. The cost of manufacturing till phase 3 ഒരു രൂപ പോലും phase 3ക്ക് ശേഷം മാത്രമേ മാർക്കറ്റ് വരുള്ളൂ, രൂപ കിട്ടുള്ളൂ. Correct? Not even $1 was recovered from selling torcetrapib. അത് MCQ ഒന്നുമില്ലായിരുന്നു. എന്തോന്നു CAയുടെ പരീക്ഷ. Yes. The cost of products producing torcetrapib was $800 million from phase 1 to phase 3. $800 million. $800 million ഒറ്റയടിക്കിതാ പോയി. ഒന്നും തിരിച്ചിട്ടില്ല. $800 million equals to 4,000 crores. 4,000 crores equals to Delhi Metro. ഒരു മരുന്നിന്റെ വിലയാണ് equivalent to ഒരു ഡൽഹി മെട്രോ. ക്ലിയർ? സോ അതുകൊണ്ട് വളരെ കാര്യത്തോടെ മരുന്ന് പഠിക്കണം. കേട്ടില്ല? So these are the drugs. Next, alteration of penicillin binding proteins is classically the type of resistance strain in MRSA. ഒരു ഇതിന്റെ ബേസ് ചെയ്യുന്നുണ്ട്. ഒരു പ്രീവിയസ് ഓൾ ഇന്ത്യ 2008 ചോദിച്ചാൽ which of the drugs are not effective against MRSA? Which of the drugs is not effective against MRSA? The answer was vancomycin, 2 imipenem, 3 doxycycline, 4 cotrimoxazole. What will you answer? ഈ ക്വസ്റ്റ്യൻ കണ്ടുപിടിച്ച ഏതൊരു ശരിക്കും ബുദ്ധിമാനാണ്. കാരണം നിങ്ങളുടെ ടെക്സ്റ്റിനകത്ത് ഒരു തെറ്റുണ്ട്. അതിനെ കറക്റ്റായിട്ട് MCQ ആയിട്ട് എടുത്തിട്ടുണ്ട്. Imipenem is useful in some forms of MRSA. അത് അബ്സല്യൂട്ട് നോൺസെൻസ് ആണ്. അതെങ്ങനെ പറ്റും? ഇതിനെ പെൻസിൽ ബൈൻഡിംഗ് പ്രോട്ടീൻ മോഡിഫൈ ചെയ്തു കഴിഞ്ഞാൽ പിന്നെ സം ഫോം ഓഫ് MRSA എങ്ങനെ ആക്ട് ചെയ്യും? ശരിയല്ലേ? Imipenem is absolutely useless against MRSA. മനസ്സിലാകുന്നുണ്ടോ? So the answer is imipenem. Is classical saying MRSA 2 pneumococci. A frequent question for you. A patient admitted with pneumococcal meningitis was given injection ceftriaxone or cephalosporin penicillins for immediately with some initial improvement the patient went in for clinical worsening. Here, what will be the next drug you will add? Concept എന്ന് പറഞ്ഞാൽ the most, if penicillins കൊടുത്തിട്ട് the moment you give penicillins and the patient does not respond, if it is pneumococci, you give penicillins and if it does not respond, that means it has modified the penicillin binding protein. One of the most important or common mechanisms of resistance in pneumococci. pencil binding protein modify, then the answer will be vancomycin. In such a situation, the only option is vancomycin. Did you understand the question? Question is the patient was given beta lack of antibiotics having irregular beta times. The patient initial response in a clinical deterioration. That means what? It is MRSA. It is not MRSA. It is the target is modified. Pencil binding proteins are modified in pneumococci. Did you understand? Pneumococcal meningitis. Then after next target, the answer will be vancomycin. Enterococci. And enterococci. Is it clear or not? So what did we do, humans do? We found out vancomycin. So that it does not need pencil binding protein. Correct? Yes or no? So what did bacteria do? Bacteria went to naturally. Indinum kandu Japan. To meet their friends, the Japanese enterococci, who gave them a gene, Van A gene. See, Japan alkarim bacteria highly advanced now. Clear? And thus we got the superbug. So what did we do? So because of Van A gene, what happens? Bacteria, instead of using dala, will now start utilizing D-lactate. But D-lactate I have no vancomycin attached. Can you understand the concept? A targeting magical. And thus was born VRSA. Clear? Tell me, the drug of choice in VRSA is? Yes? Linezolid. An alternative to linezolid is? Correct. Streptogramins. It is a combination of chinopristine, dalfopristine. That is a French drug, pristinamycin kandupidichadanu. Pristinamycin. That is streptogramins. Streptogramins is chinopristine, dalfopristine. You can also use linezolid. This was clear? Resistance in gram-negative bacteria. In gram-negative bacteria, it has an additional porin, see, one layer glycopeptide or we can lipoglycopeptide, one layer. Clear? The problem with this layer is, additional layer is, most of the drugs are impermeable. Most of the drugs, mukya antibiotics clear? Antibiotics can only go into the gram-negative bacteria through specialized channel called porin channel. Through porin channel. This porin channel carry ponamengil, the drug should be small in size. And two, they should be highly polar. And after carry ponamengil, it should be small in size and highly polar. This much clear? Small in size and highly polar. Addukunta, the aminoglycosides, which are very small in size and highly polar, easily go through the porin channel and are very effective against gram-negative bacteria. While penicillin G, vancomycin, methicillin, proxacillin, oxacillin, they do not go through the porin channel. Why? Because they are huge bulky molecules. On this was based a question, which of the following is not effective in pseudomonas? 1, all year 2006. 1, listen, 1, ceftazidime, 2, astrionum, 4, 3, vancomycin, and 5, gentamicin. Correct, vancomycin is immediately. The pouring channels for pseudomonas are more smaller and sophisticated. As you go large molecules, will go with. So answer is vancomycin because it does not have anticerebral activity. It does not have anticerebral activity because of its large size. Next, what am I going to do? Smaller penicillins, correct? Ampicillin, piperacillin, which goes easily inside. So bacteria do bacteria develop, yes, beta-lactamase, which can destroy the penicillins, which we call it as broad spectrum beta-lactamase. We should call it as broad spectrum beta-lactamase that can destroy all penicillins and all first generation cephalosporins. These beta-lactamases are classically plasmid mediated, which can destroy all penicillins and all first generation cephalosporins. We develop the third and fourth generation cephalosporins that are highly resistant to plasmid mediated, yes, beta-lactamase. The fourth generation are also resistant to chromosomal beta-lactamase. Extremely high resistance requirement with chromosomal beta-lactamase. For that, you can use fourth generation. So broad spectrum beta-lactamase is a blockade and you develop third and fourth generation cephalosporins. Clear? So what did bacteria do? What bacteria do? A broad spectrum beta-lactamase ne extend to produce extended spectrum beta-lactamase. EL. The most frequent question for you in examination. The English sequential ones will be able to answer the questions. If you may get confused, may go wrong. ESBL. Extended spectrum beta-lactamase. Correct? Correct? Spectrum extended. It also now includes all penicillins, all cephalosporins and even monobactam. And even monobactams. Clear? Clear? See, look at this. Chila book il and book Rajesh Khanna, Mohammad Rafi ne book kontida. Book Mujib Khanne. Rajbabara. Ashish Gupta, answer astrionam. Against ESBL producing, every book against ESBL producing Klebsiella. Tettana. Astrionam cannot be used. Then and the backer from Harrison 17 division. Harrison Army Muri, Harrison a Martian. Harrison 17 division. Absolutely, Astrionam we can. So ESBL combat and what did it bring? A highly stable, sophisticated, very long spectrum on the drug carbapenems, extremely resistant to hydrolysis. So what did bacteria bring? Bacteria in the ultimate arsenal. Which one? The classic name 16. Metallo-beta-lactamase, which can destroy all carbapenems. That is the one type which we saw in the New Delhi type 1 strain. That is, which produces metallo-beta-lactamase producing strain of E. coli and Klebsiella. അങ്ങനെ വന്നു കഴിഞ്ഞാൽ പിന്നെ carbapenems ഉപയോഗിക്കാൻ പറ്റില്ല. The metallo-beta-lactamase പറയാൻ കാരണം it contains zinc, which can destroy all beta-lactam antibiotics, which is resistant. Then what will be the drug of choice? There are only two drugs that has been shown to be effective. One, tigecycline, which is the latest tetracycline analog, which we call as glycine cycline. And two, polymyxin. Polymyxins and tigecycline are the only two drugs that are effective against carbapenemases. Clear? ചില ബുക്സ് കൊടുത്തിട്ടുണ്ട് ടൈഗർ സൈക്ലിൻ. അതല്ല, തെറ്റാണ്. ടൈഗർ എന്നല്ല, ഇത് tigecycline ആണ്. ESBL is most prevalent in gram-negative bacilli like Klebsiella and E. coli. This Harrison, they are the most reliable are carbapenems. Don't write down, you already discussed this. Plus cefabazines and carbapenems. Tigecyclines and polymyxins are the most effective against carbapenems producing Klebsiella and Helicobacter. Make it. We already discussed it. Here, now take the questions that you have answered and see how much you have got it right. ആര് ടിക്ക് ചെയ്തില്ലേ ആൻസർ? ആരും ആൻസർ ടിക്ക് ചെയ്തില്ലേ? ടിക്ക് ചെയ്തില്ല. എന്താ ടിക്ക് ചെയ്യാത്തതിന്റെ കാരണം? നോക്കുമ്പോ അറിയായിരുന്നു പാടാണെന്ന്. പിന്നെ ശരി ശരി. Now see how easily you can answer. ആൻസർ ടിക്കേ ഞാൻ നോക്കട്ടെ എത്ര മാത്രം ശരിയാണല്ലോ. ഇതാണ് കൺസെപ്റ്റ് ഓറിയന്റഡ് ലേണിംഗിന്റെ അഡ്വാൻറ്റേജ്. ഇനി എങ്ങനെ അങ്ങോട്ട് ഇങ്ങോട്ട് എന്ത് ചെയ്താലും വിൽ നോട്ട് ഗോ റോങ്. കൺസെപ്റ്റ് എന്ന് വെച്ചാൽ യു ക്യാൻ ഓൾസോ ഈസിലി ആൻസർ ദ ഹയസ്റ്റ് ക്വസ്റ്റ്യൻസ് ഇൻ ഫാർമക്കോളജി. മാക്സിമം ഹയസ്റ്റ് ക്വസ്റ്റ്യൻസ് വരുന്നത് അപ്പൂജിയ എന്ന് പറഞ്ഞ സ്ഥലത്താണ്. ആ ക്വസ്റ്റ്യൻ പോലും യു ക്യാൻ ഈസിലി ആൻസർ ഇറ്റ്. ഒന്നുമല്ല, യുവർ കൺസെപ്റ്റ് ഈസ് ക്ലിയർ. ആൻസർ ബിജോ ആറാമത്തെ നിലയാണ്. തെറ്റിയാൽ എവിടെ ഒഴിക്കൂ. All the following act on cell membrane except. What is the answer? What is the answer? Yes? ആണല്ലോ. Is it very clear now? resistance of pneumococci to penicillin is by previous MCക്ക് ചോദിച്ചത് altered target എന്നുള്ളൂ. അത് സെയിമാണ്. altered target നാം തന്നത്. അതും ശരിയാണ്. ശരിയല്ലേ? കൺഫ്യൂഷൻ ഉണ്ടെങ്കിൽ ഇമ്മീഡിയറ്റ്ലി ബാക്കി ചോയ്സ് വെച്ച് റൂൾ ഔട്ട് ചെയ്യുക. altered ഡാല ശരിയാണോ? പ്രൊഫഷണൽ പെൻസിലിൻ ശരിയാണോ? ഡിക്രീസ് പെർമിലിറ്റി ശരിയാണോ? A diabetic patient develops cellulitis due to staphylococcus aureus, which is found to be medicine resistant. All can be used in the patient except. Yes? Fine. A 60-year-old female is admitted with bacteremia due to gram-negative bacilli. She had a history of allergy to penicillin. Drug safely used in the patient is fine. Ibuprofen mainly as for inhibition of which is ഒരിക്കലും ചിന്തിച്ചിട്ട് പറയും. ചോദ്യം നോക്കി ഞാൻ പറഞ്ഞില്ലേ, കാര്യങ്ങൾ അറിയാം പക്ഷെ എളുപ്പം തെറ്റിക്കാറുള്ളത്. ശരിയാണല്ലോ? എന്താണ് ഉത്തരം? ചിന്തിക്ക്. ട്രാൻസ്ഫിക്രേഷൻ റിയാക്ഷൻ ശരിയാണോ? നോട്ട് ബീറ്റ ലാക്ടമേസ്. All are polypeptide antibiotics except synthesis of dala is blocked by cycloserine. Then about the vancomycin true statement is which is binds to penicillin binding protein. True statement ആണ്. ബാക്ടീരിയോസ്റ്റാറ്റിക് ആണോ? സൈഡിലാണ്. ഡോസ് ആക്റ്റീവ് വോള സൈഡിൽ. ബൈൻഡ്സ് ടു ഡി അലാനിൻ ഡി ലാക്ടേറ്റ് ആണോ? ഇത് ബീറ്റ ലാക്ടം റിംഗ് ഉണ്ടോ? ബീറ്റ ലാക്ടം റിംഗ് ഉണ്ടോ? ഇല്ല. Then how it is susceptible to beta lactamase? ശരിയല്ലേ? So the answer is not susceptible to beta lactamase. മനസ്സിലായോ? Which does not have anticerebral activity? Banco? Well, the concept is clear. You can answer any questions. Before answering the 9 question, എത്ര ശരിയായിരുന്നു ഉദ്ദേശം? ഒന്നാമത്തെ എത്ര ശരിയായിരുന്നു? 4 കൺസെപ്റ്റ് പറഞ്ഞതിന് ശേഷം 7 ശരിയായി, പിന്നെ 2 തിരിച്ചു. മനസ്സിലായോ? Beta-lactam antibiotics. Penicillins. Student showed you classification of penicillins. Classification of penicillins. എപ്പോഴെങ്കിലും പഠിച്ചിട്ടുണ്ടോ? പഠിച്ചിട്ടുണ്ടല്ലോ. ഇതൊന്നും എന്ത് മനസ്സിലായി? എപ്പോഴെങ്കിലും ഫാർമക്കോളജി പഠിക്കുമ്പോഴത്തേക്കും ചിന്തിച്ചിട്ടുണ്ടോ ഇതൊക്കെ ഞാൻ എങ്ങനെ പഠിക്കേണ്ടത്? ശരിയല്ലേ? ശരി, ന്യായമായിട്ട് ചോദ്യമില്ലേ? എങ്ങനെ പഠിക്കണം? എങ്ങനെ കാണാപ്പാടം പഠിക്കേണ്ട ആവശ്യം? ഈ മരുന്നുകളൊക്കെ വന്നപ്പോഴത്തേക്ക് കാണാപ്പാടം പഠിച്ചുകൊണ്ടാണോ വന്നത്? ഇല്ലല്ലോ. ഏതോ ബേസ്ഡ് ഓൺ സർട്ടൻ തിങ്സ് ആൻഡ് ഫോർ യൂസ് ഫോർ സർട്ടൻ തിങ്സ് ദ റീസൺസ് ആർ ഇല്ലുസിനേറ്റഡ്. അല്ലേ? ഹൗ വാട്ട് റിസർച്ച് യു ഫോർ ഗോയിങ് ഓൺ? There's no point in saying as far as this is a British system of study. British system ഉണ്ട്, American system ഉണ്ട്. Do not ever use the British system. The sun has set in the British Empire long back. That's the point. 2. ഒരു ബ്രിട്ടീഷ് സിസ്റ്റവും ഉപയോഗിക്കരുത്. ബ്രിട്ടീഷ് സിസ്റ്റം ഉപയോഗിക്കേണ്ട ക്ലാസിക്കൽ എക്സാമ്പിൾ ആണ് നമ്മുടെ കണ്ണിംഗ്ഹാം. ഇംഗ്ലീഷേ മനസ്സിലാവില്ല. ഇംഗ്ലീഷ് മനസ്സിലായാലേ പിന്നെ അതിനകത്തുള്ളൂ മനസ്സിലാവുള്ളൂ. കാരണം ആ ഇംഗ്ലീഷ് വായിച്ചാണ് ഓരോ കുട്ടികൾ ഇടയ്ക്കിടയ്ക്ക് ഇങ്ങനെ വീഴുന്നത്. ആൾക്കാർ എല്ലാവരും പറയുന്ന ഫോർമലിൽ വിശ്വസിച്ചാണ്. അല്ല, പിന്നെ ഇംഗ്ലീഷ് കാരണമാണ്. അപ്പോൾ ശരിയല്ലേ? Absolutely, our days are gone. All those days, our British days are gone. British books they always give importance to British English. We should always join hands with Americans in destroying this British English. കാരണം നമുക്ക് അതിന്റെ ആവശ്യമില്ല. ഈ ബ്രിട്ടീഷ് ഇംഗ്ലീഷിന്റെ ആവശ്യം നമുക്കെന്തിനാ? അമേരിക്കൻസ് ചെയ്യുന്നത് നമ്മൾ ചെയ്യണം. അതുകൊണ്ട് together we can make the world a English free zone. അവരവർക്ക് ഇഷ്ടമുള്ള ഇംഗ്ലീഷ് അവരെ ഉപയോഗിക്കും. കാര്യം മനസ്സിലാക്കോടെ ശരിയല്ലേ? അല്ലെങ്കിൽ ബ്രിട്ടീഷ് ഫോർ എക്സാമ്പിൾ ബിറ്റ്വീൻ പെസിഡിൻ ആൻഡ് മെപ്പിഡിൻ, സക്സാമെത്തോണിയം സക്സിനെപ്പിളിയും കൊള്ളാമുണ്ടോ? Benz XL try XC field है. So what is what we call the British nomenclature. British nomenclature എന്ന് പറയുന്നത് അവരുടെ ആക്സെന്റ് കൂടെ അതിനകത്തുണ്ട്. ഫൂസിമൈഡ്. അമേരിക്കൻസ് അത് പറയും, നമ്മൾ അങ്ങനെയൊന്നുമില്ല, നമുക്ക് ഇഷ്ടമല്ല. ഫൂറോസമൈഡ്, ഫൂസിമൈഡ് പറയാൻ ബുദ്ധിമുട്ടാണ്. ബ്രിട്ടീഷേഴ്സ് പറയും adrenaline. കാരണം it is obtained synthesized from the adrenal gland. അവരുടെ ആക്സെന്റ് ഇംഗ്ലീഷ്. അമേരിക്കൻസ് അഡ്രീനൽ എന്ന് പറയുന്ന പ്രയാസമാണ് പറയാൻ. ഈ അഡ്രീനൽ ഗ്ലാൻഡ് എന്ന് പറയുന്നത് കിഡ്നിയുടെ മോഡലല്ലേ? അപ്പൊ നമ്മൾ ഇതിൽ കോഴിക്കോട് എപ്പിനെഫ്രീൻ, മറ്റേ സക്സാമെത്തോണിയം, ആ ഇംഗ്ലീഷ് ആക്സെന്റ് ഉണ്ട്. അമേരിക്കൻസ് പറയും ഇതൊന്നും ഇവിടെ നടക്കില്ല, രണ്ട് മോളിക്കുലർ അവസ്ഥയെക്കുള്ളിൽ ജോയിൻ ടുഗദർ, സോ ഇറ്റ് ഈസ് സക്സിനെക്കുള്ളിൽ. ബ്രിട്ടീഷേഴ്സ് പറയും റിഫാംപിൻ, റിഫാംപിസിൻ. അമേരിക്കൻസ് ഇത്രയും പറയാൻ പറ്റില്ല, റിഫാംപിൻ. അമേരിക്കൻസ് പറയും ബ്രിട്ടീഷേഴ്സ് ലിഡോക്കെയിൻ, ലിഗ്നോക്കെയിൻ. അമേരിക്കൻസ് ലിഡോക്കെയിൻ. ബ്രിട്ടീഷേഴ്സ് പെത്തഡിയൻ, അമേരിക്കൻസ് മെപ്പരിഡിയൻ. എല്ലാ അമേരിക്കൻ ബുക്സിലും അമേരിക്കൻ ന്യൂസ് മാത്രമേ കാണൂ. ഹാരിസൺ, ഗുഡ്മാൻ, അത് മാത്രമേ കാണുള്ളൂ. ബ്രിട്ടീഷ് ബുക്സില് ഫുറോസിമൈഡ് ബ്രാക്കറ്റിൽ ഫുറോസമൈഡ്, പെറ്റഡിൻ ബ്രാക്കറ്റിൽ മെപ്പിലിഡിൻ. വൈ അങ്ങനെയാണ് ലോകമെങ്കിൽ നമ്മൾ എന്തിനാണ് ബ്രിട്ടീഷ് കാര്യങ്ങൾ പഠിക്കുന്നത്? ഈ ബ്രിട്ടീഷ് സിസ്റ്റം പഠിച്ചത് കൊണ്ടാണ് ത്രിപാഠി അത് എഴുതി വെച്ചിട്ടുണ്ട്. ത്രിപാഠി സാറിന് മനസ്സിലായിട്ടില്ല, പഠിക്കുന്നവർക്ക് മനസ്സിലാവുന്നില്ല. ബിക്കോസ് ഓഫ് ദ സിസ്റ്റം. പണ്ടേ നമ്മൾ ഈ സാഹിത്യത്തെ ഓടിച്ചില്ലേ, ബ്രിട്ടീഷുകാരെ ഓടിച്ചില്ലേ, അതിന്റെ കൂടെ ഇംഗ്ലീഷ് കൂടെ ഓടിക്കുമായിരുന്നു. വി ഹാവ് അണ്ടർസ്റ്റുഡ് എ ലോട്ട് ഓഫ് തിങ്സ്. ദ വേൾഡ് ഹാസ് ചേഞ്ച്ഡ് എ ലോട്ട്. അവരോട് എന്തുകൊണ്ടാണ് ഒത്തിരി ചിന്തിച്ചിട്ടുണ്ടാ? ബ്രിട്ടീഷ് ബുക്സിൽ ഓക്സ്ഫോർഡ് ടെക്സ്റ്റ് ബുക്ക് ഓഫ് ഫാർമക്കോളജി എടുത്തു നോക്ക്, ബ്രാക്കറ്റില് ഫുറോസമൈഡ്, ബ്രാക്കറ്റിൽ മെപ്പിലിഡിൻ കാണും. ബൈ സിമ്പിൾ ലോജിക്കാണ്. ബ്രിട്ടീഷേഴ്സ് ആർ അഫ്രൈഡ് ഓഫ് അമേരിക്കൻസ്. അവർ ബ്രിട്ടീഷ് ടേംസ് ബ്രിട്ടീഷേഴ്സ് അമേരിക്കൻ ടേംസ് ഉപയോഗിക്കാൻ പറ്റിയെന്ന് പറഞ്ഞാൽ എവിടെ ഹാപ്പൻ? ഒന്നും സംഭവിക്കില്ല. ഒരു 3 സ്ക്വയർ ഓഫ് 16 ആ ലോസ് ആഞ്ചലസ് വേസിൽ പോകും. 10 ഡൗണിംഗ് സ്ട്രീറ്റ് ലണ്ടൻ ബ്രിഡ്ജ് അതിന്റെ മുകളിൽ കൂടെ ചുറ്റി കറങ്ങി തിരിച്ചു പോകും. മെസ്സേജ് കൊടുക്കും, ക്ലിയർ. പിന്നെ ബ്രിട്ടീഷേഴ്സ് ആണ് ഡെഫിനിഷൻ. എന്തിനാ ഡിഫൈൻ ചെയ്യേണ്ട കാര്യം? ഡിഫൈൻ യുവർ ഫാദർ. ഈ ഫാദർ ആരാണെന്ന് അറിഞ്ഞാൽ പോരെ? പലർക്കും പല ഡെഫിനേഷൻസ് കാണും. പല കാര്യം അറിഞ്ഞാൽ പോരെ? പിന്നെ ഡിഫൈൻ ഹെൽത്ത്. Define health. Why? That's a British system. Hello, define health. Health is defined socially, mentally, physically, sexually, psychologically, and by 2020 health കൊണ്ടുവരുമ്പോൾ നടക്കുന്ന കാര്യമാണ്. മാത്രമല്ല, who is WHO define my health? എനിക്ക് So those systems have gone. Our system already has gone. Everything has now become a concept oriented. Is that clear? It is absolutely very clear. This is Britishers CEF, CEF എന്ന് പറയും. CEF. Americans CPH എന്നാലുണ്ട്. Why? I know when British troops, when they invaded Italy, Britishers പറഞ്ഞു, Professor Godsu gave cephalosporins to us with love and honor at gunpoint. എന്നാണ് ബ്രിട്ടീഷേഴ്സ് പറഞ്ഞത്. അമേരിക്കൻസ് പറഞ്ഞത് അതൊന്നും നമ്മളെ ബാധിക്കുന്നതല്ല, അത് നിങ്ങൾ സ്നേഹത്തോടെ തന്നതോ തോക്ക് ചൂണ്ടി തന്നതോ അതൊന്നും അമേരിക്കയെ സംബന്ധിച്ചോളം ബാധിക്കുന്ന കാര്യമില്ല. whichever drug is produced on the earth is ours. You understand? ഇതാണ് അവരുടെ സ്റ്റൈൽ. Don't go on to entrance, don't go on to study all those definitions. ഇത് വെച്ചൊന്ന് ഒരിക്കലും you will never be able to answer any of the questions. എന്തെങ്കിലും ഒരു കാർബോക്സിൻ പേഷ്യന്റിന് കൊടുക്കുമ്പോഴത്തേക്ക് ഇങ്ങനെ ചിന്തിക്കുമോ, ഇത് യൂരിഡോ പെൻസിലാണ് നമ്മൾ കൊടുക്കേണ്ടത് അതോ കാർബോക്സി പെൻസിൽസ് ആണോ? ഹൗ ഡു യെസ് ഒരൊറ്റ ക്വസ്റ്റ്യൻ പോലും ആൻസർ ചെയ്യാൻ പറ്റില്ല. ഒറ്റ ക്വസ്റ്റ്യൻ പോലും ഈ വെച്ച് ആൻസർ ചെയ്യാൻ പറ്റില്ല. ഗോ ബൈ സിമ്പിൾ വേ. അമേരിക്കൻ സിസ്റ്റം നാച്ചുറൽ പെൻസിൽസ്. സി ഐ ഡോണ്ട് ഹാവ് എനി അഫിനിറ്റി ഫോർ അമേരിക്കൻസ്. എനിക്ക് ഇഷ്ടമില്ലാത്ത ആൾക്കാരാണ്. പക്ഷേ അവർ ബ്രിട്ടീഷ് ഇംഗ്ലീഷ് നശിപ്പിക്കുന്നത് കാണുമ്പോഴത്തേക്കും സന്തോഷം. Classification: natural penicillins, anti-staphylococcus penicillins and extended spectrum penicillins. See, natural penicillins എന്ന് പറയുന്നത് ബെൻസൽ പെൻസിലിൻ, പെൻസിലിൻ ജി, procaine penicillin, benzapine penicillin. They are penicillinase sensitive or beta-lactamase sensitive. Anti-staphylococcus penicillins naturally എന്താ പറയുന്നത് beta-lactamase stable അല്ലേ? Yes or no? Extended spectrum എന്ന് പറഞ്ഞാൽ that does not mean they are resistant. The spectrum is extended. They are also beta-lactamase sensitive. Beta-lactamase sensitive, correct? Yes, clear? Now look at the one. Natural penicillins are beta-lactamase sensitive divided into two, which you can use orally or an acid stable. Phenoxymethyl and phenoxyethyl penicillins, penicillin V, which we call acid labile, are penicillin G, procaine penicillin, benzapine penicillin. The procaine is highly allergic. It can precipitate seizures. Benzapine penicillin is the longest acting. ഈ ക്രിസ്റ്റലൈൻ പെൻസിലിൻ എന്ന് പറയുന്നതും പെൻസിലിൻ തമ്മിൽ വ്യത്യാസമില്ല. ബെൻസാറ്റിൻ പെൻസിലിൻ. This was clear? Yes? Beta-lactamase resistant. We divide into two. Acid stable. Other cloxacin, oxacin. And acid labile, which has to be given parenterally. Acid labile. Acid stable, which we are, and the prodrugs bac-ampicillin, tal-ampicillin. The anti-acid labile are piperazine, meslocin, acetylocin. What do you call them? They are anti-pseudomonal penicillins. They are what we call anti-pseudomonal penicillins. Reverse spectrum penicillins, mesalinam. That means they are active against only gram-negative bacteria. Unlike penicillins, they are bacteriostatic. Clear? So based on this classification, you answer the next two questions and then take your tea break. getting anaerobes they are active, not at all active against MRSA and Clostridium difficile. One of the major limiting factors for use of carbapenem like imipenem is one of the main problems. Serious infections usually without a problem done. Seizure. The main side effects is seizures. They are excellent active against Enterobacteriaceae, Pseudomonas and Bacteroides. Carbapenems. Imipenem, ertapenem, meropenem. Just a minute. Why? Tell me, why imipenem is combined with cilastatin? Is dehydro? What is inhibited? Inhibited by what? Take it. Why do you use cilastatin along with imipenem? Cilastatin inhibits the enzyme dehydropeptidase. Dehydropeptidase is responsible for degrading imipenem. Followed. So the destruction of imipenem is reduced. As a result, what will happen to imipenem? As a result, where? Yes, so what happened to imipenem? Yes? Correct. So the T-half of imipenem is increased. Wrong. തെറ്റാണ്. അതറിയാം അവസാനം അത് കറങ്ങി തിരിയാതെ വരുള്ളൂ. തെറ്റാണ്. അത് ഞാൻ ഒരുപാട് ചോദിച്ചിട്ടുള്ളത്. തെറ്റാണ്. അങ്ങനെയല്ല. What happens is, as imipenem goes through the proximal tubule, which contains brush border cells, it is acted upon by dehydropeptidase. Correct? And very few amount of imipenem comes to the urine. Very few amounts of imipenem which comes to the urine, the urinary pathogens will develop resistance to imipenem very fast. ശരിയാണല്ലോ? To counter this, ഒരു കാര്യം ചെയ്യാൻ പറ്റുള്ളൂ. Increase the dose of imipenem. Yes or no? To get very high urinary conservation. What will happen? Seizure addictive. So use a drug that blocks dehydropeptidase. As a result, cilastatin, when it is used, it will increase the urinary concentration of imipenem, not biological half-life. It's not half-life, but urinary concentration. 2. Imipenem, as it comes through the brush border cells, as it comes through the brush border cells, is acted upon and destroyed by dehydropeptidase. A toxic metabolite is formed. Or the products of imipenem, when it is destroyed, forms toxic metabolites which can produce proximal tubular necrosis. Cilastatin, when used, can prevent that also. So cilastatin is used to increase the urinary conservation plus reduce the renal toxicity of imipenem. Reduce renal toxicity and increase urinary imipenem. While ertapenem and meropenem do not produce seizures and you did not use cilastatin because it is not degraded by the hydropeptidase. That is the reason why you use commonly meropenem. CNS infections, you can use meropenem but not imipenem. Monobactams, Astrionam. Ertapenem disadvantage, it is not effective against Pseudomonas. That's its main disadvantage. Next, monobactams, anaerobes, no activity, only gram-negative bacteria, pregnancy, tune, nephrotoxicity, two things are bypassed. You don't have any problem when you use Astrionam. No nephrotoxicity can be used safely in renal failure patients in pregnancy. But what's the difference? One ampule of gentamicin will cost you how much rupees? 80 quality. 18, maximum 10, 12, 18 IRPG. One ampule of Astrionam will cost you? How much? Ekra? Any idea? No idea, very good. It costs 2,000. That's the only difference. Vancomycin acts on gram-positive bacteria, ototoxicity, nephrotoxicity, red man syndrome. Red man syndrome. Okay. The question they asked for, why is red man syndrome due to? Oh, someone too. This is another question. Red man syndrome due to vancomycin is 1. Idiosyncratic, 2. Allergic, 3. Dose related, 4. Genetic. Idiosyncratic, tetad. Genetic, absolutely wrong. Allergic, wrong. Remember, dose related, because the ability of vancomycin to produce degranulation in mast cell depends on a particular plasma concentration of vancomycin. Our plasma immediately degranulation. Hence it is dose mediated. The toxicity of vancomycin can be reduced, or red man syndrome can be reduced by reducing the infusion rate of vancomycin. Then the second one, based on which a lot of questions were asked, can you tell me the drug, most potent drug that can induce the release of histamine? Correct. It is morphine. In vitro, നമ്മൾ മോർഫിൻ ആഡ് ചെയ്താൽ പോലും മാസ് ഡീഗ്രാൻഡേറ്റ് മോർഫിൻ. അതും വേണ്ട, മോർഫിൻ എഴുതി കാണിച്ചു കൊടുത്താൽ മതി. ടെസ്റ്റ് വിത്ത് മാസ് ഡീഗ്രാൻഡേറ്റ്. So potent it is. Is that clear? The most potent or the most potent drugs that can cause degranulation of mast cells. MRSA, Enterococcus in patients allergic to penicillin, penicillin resistant pneumococci, are the indications of vancomycin. Daptomycin, Enterococcus, Pneumococcus, MRSA. Main side effect is myopathy. It is inactivated by surfactant present in the lungs. Enterococcus gram positively. Enterococcus ഇൻകൊളയാണ്. Clear? Okay. You answer the questions which we have discussed. Questions? From 14 to from 12 to 12 is already 2007 question. 12 to 22. Yes, all are therapeutic uses of penicillin G except. Sorry, which about ampicillin is not accurate? Analo. All are third generation except Cepha? Mandor. Disulfide reaction hyperprothrombin is side effect of Cepha theta is mainly effective against theta in the Cephamycin ആണോ? In a patient with chondrolithiasis, the drug you will avoid is CNS penetration is poor for Aspirinum should not be used if the patient is allergic to. The most appropriate treatment for gonorrhea in a patient allergic to penicillin is അതുപോലെ പറഞ്ഞപ്പോഴത്തേക്കും ഉത്തരങ്ങളുണ്ട്. എന്റെ മൂത്രം നോക്കിയോ? What is pectinomycin? വാങ്കോമൈസിന്റെ കഞ്ചിത് ആര് പറഞ്ഞത്? ആര് പറഞ്ഞത്? വാങ്കോമൈസിനായിട്ട് പഠിപ്പിച്ചുകൊണ്ടിരിക്കുന്നുണ്ട്, അതിന്റെ ബന്ധമായിരിക്കുമെന്ന്. Pectinomycin, what is it? Amino glycoside ആണോ? See, basically നമുക്ക് കിട്ടുന്ന എല്ലാ അമിനോ ഗ്ലൈക്കോസൈഡ്സ് എന്ന് പറയുന്നത്, that is ജെൻഡാമിസ്, എനാമിക് ആസിഡ്, എല്ലാം പ്യൂർ അമിനോ ഗ്ലൈക്കോസൈഡ് അല്ല. പ്യൂർ അമിനോ ഗ്ലൈക്കോസൈഡ് എന്ന് പറയുന്നത് ഒരെണ്ണേ ഉള്ളൂ. There is kasugamycin. അത് ജാപ്പനീസ് ആണ്. കസുഗാമൈസിൻ. പ്യൂർ അമൈനോസൈക്ലിറ്റോൾ എന്ന് പറയുന്നത് ഒരെണ്ണേ ഉള്ളൂ, സ്പെക്ടിനോമൈസിൻ. നമുക്ക് കിട്ടുന്ന എല്ലാ അമൈനോ ഗ്ലൈക്കോസൈഡ്സ് എന്ന് പറയുന്നത് ആ ബേസിക്കലി അമൈനോ ഗ്ലൈക്കോസിഡിക് അമൈനോസൈക്ലിറ്റോൾ. പക്ഷെ നെയിം വൈസ് നമ്മൾ അമൈനോ ഗ്ലൈക്കോസൈഡ് എന്ന് പറഞ്ഞു തന്നെയാണ്. Pure aminocyclitol is spectinomycin. The indication of spectinomycin ആണെങ്കിലും it is somewhat different from aminoglycoside. Clear? Aminoglycoside cannot be given in pregnancy, but the indication of spectinomycin is in patients with gonorrhea, especially pregnant who is allergic to penicillins. It can be safely used in pregnancy in a pregnant patient who is allergic to penicillins. Upon a pregnant patient, you cannot use quinolones also. For beta-lactam is producing enterococci, all are used except ceftriaxone. Beta-lactam antibiotic is not useful in treatment of anaerobes. Yes? Fine. How many of you were there last year? Any one of you were there last year? Yes? Can you extra class here? You were there. So this is one new technique I am using. The first time no one has tried this technique, but many places have tried this technique and it is working out to be very good. Last time, or most of the other faculty, all other faculties, last time also I also used to use the primitive style, that is, question area, question going to answer area. Follow? But nowadays I changed it, concept area, and you answer it. Follow? But the reason is because in this way you will be trained to walk on your own. But here, the problem is that there is some amount of spoon feeding ordered. This thing is pure concept and then you are asked to solve on your own. Which one do you find is better? This is better. And you just take it as from that now. You don't answer. Where are the Okay, fine. Usually nowadays I'm very angry, I don't have a problem. Periodically I stopped scolding them or criticizing them. Now I reacted, we can't say. I had a nasty incident. I scolded one girl. So I asked her where beta-2 receptors, musculoskeletal muscles, where are they present? She said, which area of musculoskeletal muscles they are present? She said, bronchial smooth muscles and uterus. Bronchial smooth muscles and uterus and musculoskeletal system. Smooth muscles only. Then I asked her, who the hell taught you pharmacology? Who gave you taught the child which. And she named it. It's outside Kerala. So she named Tamil Nadu. She named a madam. So I said, oh, no matter. I knew that madam. Naturally. If she teaches you, you will be answering this way. Yatha Guru Tada Shishya. Go and study again and then come back, I said. Immediately she started crying. I said, I didn't scold you. Why you are crying? I scolded your madam, no. Why you are crying? I was crying and then she was taking a tissue paper. Come on, tissue paper, in between I was explaining something, she was not. I said, okay, fine, I'm sorry. What's the problem? Sir, that madam is a mother. When she has some nasty incidents, I can't forget that. So he says, you can't think where you end up. Yes. So photosynthesis inhibitors, നല്ല beautiful diagram. കണ്ടല്ലോ, ബാക്ടീരിയയ്ക്ക് വേറെ കൺഫ്യൂഷനാണ്. ഞാൻ ഇങ്ങനെയാണോ പ്രോട്ടീൻസ് ഉണ്ടാക്കുന്നത്? ക്ലിയർ? വാട്ട് ആർ ദ ബ്രാഞ്ചസ് ഓഫ് ഫാർമക്കോളജി? അറിയാലോ, കൈനറ്റിക്സ്, ഡൈനാമിക്സ്, പിന്നെ എക്കണോമിക്സ്, pharmacovigilance, pharmacoepidemiology. Two more aspects ഉണ്ട്. ഇതിൽ ഒന്നാണ് ഇത്, what we call pharmacoconfusion. ഇതെല്ലാം പഠിച്ചു കഴിയുമ്പോഴത്തേക്ക് നമ്മൾ ബുക്കെല്ലാം വലിച്ചു കയറി ദൂരറി. Pharmacoviolence. We study this in a different way. Drugs interfering with protein synthesis. India, do we have that mouse? Yes, drugs interfering with protein synthesis are divided into those acting on 30S and those acting on 50S. Those acting on 30S, you can omit SAP, ACS, and those act on 50S. Mouse and yes, tetracyclines, aminoglycosides, pectinomycin 30S. Others act on yes. Clindamycin, that is old name for clindamycin is lincomycin. And the name was lincomycin. Next, you can see over here. So study this thing in a different way. mRNA comes attaches attaches, 50S comes attaches, you get a initiation complex, correct? Yes or no? Tell me about the drug that blocks initiation complex. Tell me. Tell me about the drug that blocks initiation complex. Yes? See, be very clear about those acting on 30S and 50S. Many times they ask you, or high level they ask. Simple and once I had one interesting thing, 30S and 50S. MBBS since it is a PG, you have to be very clear about it. Once a question was asked, tetracyclines act via fill in the blanks, university question, dash ribosome. Clear? So, one of the students wrote, so he or she, I don't know, was confused whether it is 30S or 50S. So got the most beautiful of all answers. For 30 years I have a doubt only. But I have some 50 years to I today. Okay. Actually I gave pass mark for that humor. What the answer? Yes. Next. Initiation complex. One, you have aminoglycoside. Which is now aminoglycoside. Pencil will combine here. Ambigenda. But aminoglycoside, tetracycline combine here. Why? It should never be combined. Why? The concept is sidal plus sidal is agnostic. Synergism. Agonist antagonist. What is agonist antagonist? Efficacy, intrinsic activity. That is in the window. Mutually like potency, efficacy. Simple terms. A potency efficacy is similar receptor agonist. And one attached to the agonist receptor. Seriously, receptor agonist attached. Fine. And the same you can consider as a college days boy and a girl. A boy and a girl. Here in college days you might have seen. If boy and a girl have an affinity towards each other, seriously? Seriously? Yes or no? What do you call that? Affinity potency in the potency measure simple. Boy, a poor boy and a penguin chose similar canarly. In the penguin chose I'm going to show you the penguin. Cinema is very much a show. Yes? Yes? How much do you love me? The amount of love. Amount of potency. That potency of a drug relates to the amount of drug. Simple terms against Indijavadi. If they get married, which they usually doesn't occur, if they get married and have children, then we call it as the efficacy, the maximum effect that can always come. Hold on? Yes. So that is the difference between potency and efficacy. Next. if you use Seidel plus Seidel drug, we have synergism. Seidel plus static is antagonism. Why? Because Seidel drugs act on rapidly dividing bacteria. Analo. Static drug കൊടുത്താൽ ഇതിന്റെ division stop ആയി പോകും. Seidel drugs act ചെയ്യാൻ പറ്റില്ല. So Seidel plus static is antagonism provided the organism is less sensitive to Seidel drug. Provided the organism is less sensitive to Seidel drug. Classical example, INH rifampicin pyrazinamide, Seidel, ethambutol-static. മനസ്സിലായോ? Provided the organism is less sensitive to the Seidel drug. കുറേ നാൾ എടുക്കുക, അതുകൊണ്ടാണ് 6 മാസം ട്രീറ്റ്മെന്റ് എടുക്കുന്നത്. Did you understand? Static plus static is synergism. ഇതിനെ ബേസ് ചെയ്ത് ചോദ്യം ചോദിച്ചിട്ടുണ്ട്. ഒരു യങ് കൺസൾട്ടന്റ് ഡോക്ടർ ഒരു പോസ്റ്റ് ഓപ്പറേറ്റീവ് പേഷ്യന്റ് ആംബുലൻസിൽ സ്റ്റാർട്ട് ചെയ്യുകയാണ്. ഒരു യങ് കൺസൾട്ടന്റ് ഡോക്ടർ വന്നിട്ട് അതിന്റെ കൂടെ ഡോക്സിസൈക്ലിൻ കൂടെ സ്റ്റാർട്ട് ചെയ്തു. So instead the condition getting better, the condition became worse. Hello? So അതിന്റെ മെക്കാനിസംസ് ആണ് ചോദിച്ചത്. ഒന്ന്, അത് ശരി, ആക്ച്വലി USMLE. രണ്ടാമത്തെ ഒരു ഡിഫറെന്റ് ക്വസ്റ്റ്യൻ ചോദിച്ചത് ഇൻട്രാ അബ്ഡോമിനൽ സർജറി കഴിഞ്ഞു. Patient was started on beta-lactam antibiotics, cephalosporins, and was given and was started on along with that chloramphenicol. Condition worse is why? Cephalosporins, Seidel, chloramphenicol, static. അങ്ങനെയാണെങ്കിൽ why do you use chloramphenicol plus penicillin in meningitis? ശരിയല്ലേ? ഇൻട്രാഅബ്ഡോമിനൽ സർജറിക്കൊക്കെ ഇത് ഇവിടെ ആന്റഗണിസം, ഇവിടെ സിനർജിസം. ബൈ that depends on the effect of chloramphenicol. Clear? For organisms like E. coli, Bacteroides, Klebsiella, Pseudomonas, chloramphenicol is static. But for H. influenzae, pneumococcus, those which cause meningitis, it is Seidel. അപ്പോൾ ഇവിടെ കൊടുക്കുമ്പോൾ Seidel plus Seidel ആയി synergism. ഇവിടെ penicillin plus chloramphenicol antagonism. Did you get the idea? Did you get this? Certain drugs have different activity on different organisms. So the concept of Seidel plus Seidel is synergism, Seidel plus static is antagonism. Analo. Next. Among the protein synthesis inhibitors, the classical drug which is always Seidel is, among the protein synthesis inhibitors are basically static. Among this, the one that is classically Seidel is amino. Why? That depends on the mechanism of action of aminoglycoside. It causes, blocks initiation complex. Initiation complex it blocks, and 2, it causes misreading of mRNA. A misreading of mRNA will produce a wrong protein, which produces a Seidel effect. Wrong protein which produces a Seidel effect. Became clear? Clear? Next. Can you go over here? 30 years, 50 years, mRNA, A, P and E site. P site is an already elongated peptide chain, correct? A site is the acceptor site for accepting new tRNA with an amino acid, correct? Tell me about the drug that blocks the binding of tRNA to A site. Yes? Correct? Tetracyclines. Next. From P site, it is transferred to A site, correct? Yes or no? And a transpeptation reaction is formed, blocked by chloramphenicol. If the same type of blockade, that is blocking of 50 and 30 years, is also seen in bone marrow cells. Because bone marrow mitochondria also contains 50 and 30. That is the reason why it produces dose-dependent bone marrow suppression. 1 in 20,000 is also idiosyncratic. The main problems with chloramphenicol-induced bone marrow suppression is, main problem, it is almost irreversible. Even if the patient recovers, there is a 40% chance of secondary leukemia, AML. അതുകൊണ്ടാണ് യുഎസിലൊക്കെ it should be the last line drug. വലിയ എഫക്റ്റ് ഇല്ലെങ്കിൽ മാത്രമേ ക്ലോറാഫെനിക് ഉപയോഗിക്കുള്ളൂ. ഇവിടെ മരുന്നൊക്കെ പോലൊക്കെ കൊടുക്കും. In India it's used like anything. ഇവിടെ India is a therapeutic jungle എന്ന് പറയും. Whatever drug is banned, you get it here. Whatever drug is not approved, again you get it here. Okay? മനസ്സിലായോ? For example, diatrofloxacin was banned in US in 2007. ഇവിടെ 4 മാസം മുമ്പ് ബാൻ ചെയ്യുന്നു. So, don't be under concept that if you get a drug over here, that means that it is not banned. Go to the net and see whether the drug is banned. Indomethacin, only available in India. So, don't be under the concept. If you get a drug banned, all the drugs are banned. It's because of the side effects. Only main problem with diatrofloxacin, photosensitivity. QT prolongation and hypoglycemia. QT prolongation and hypoglycemia. Next. Even before, next surface step what is the next step over here? EA site will remember, it has to be transferred back to P site and this area has to be free. Seriously? Yes or no? So tell me about a drug, even before transfer, prematurely chain and cutting. Even before chain elongation has occurred, prematurely chain cutting. 1. Ask only for exam. Mainly all Indian aims, not used in therapeutics because of its toxicity. Now being evaluated in Chagas. Starting with P. Puromycin is now being evaluated in Chagas because its toxicity is not commonly used. Puromycin. Next. From A site, it is translocated to P site. Yes or no? That translocation is blocked by macrolides. Macrolides. One, resistance mechanisms. Target can be altered. Similar to pencil very good. Drug can be inactivated. Enzyme production, correct? And third is efflux pump. This is a classical MCQ over here for you. A monthly MCQ you can answer. One, you don't need to know it by heart. This type of efflux pump is highly active in Pseudomonas and Proteus. A highly active efflux pump is present in Pseudomonas and Proteus, which we call it as the TET pump, TET pump. Pseudomonas and Proteus called the TET pumps. That is the reason why, which is highly active in Pseudomonas and Proteus. That is the reason why Pseudomonas and Proteus is intrinsically resistant to all tetracyclines. They are intrinsically resistant to all tetracyclines. Alteration of target site is classically seen for macrolide, clindamycin, phenylprostine, dalfoprostine, that is septogramins. Clindamycin, the old name, and lincomycin, which we call MLS resistance. The MLS in the peculiarity is, if a patient is resistant to macrolide, means he will be also resistant to clindamycin. Which we call the MLS resistance. Macrolide, lincomycin, streptogramins. The most common MCQ asked for you in exam is this one. Drug inactivation. Drug inactivation is brought about by aminoglycosides and chloramphenicol. Aminoglycosides and chloramphenicol. Aminoglycoside inactivating enzyme and chloramphenicol inactivating enzyme. Can you tell me the aminoglycoside which is very resistant to aminoglycoside inactivating enzyme? Clue. Son of Kasuga or son of kanamycin. Amikacin. The congener of kanamycin. Kanamycin is not used nowadays because of extremely ototoxic. Which is the drug with highest cochlear toxicity. Naturally, father is not available. The son has a property, amikacin. Reduced drug accumulation, tetracyclines. Aminoglycosides. Neomycin is the most toxic. Neomycin is the most nephrotoxic, but it is never used parenterally. But parenterally used maximum nephrotoxicity is seen for gentamicin. Paramomycin was a previous question for you. Orally paramomycin, Vijay, can be used for ഓറലി എന്നാണ് ഞാൻ ചോദിച്ചത്. അതാണ് തെറ്റ്. മനസ്സിലായി? വിജയുടെ പ്രശ്നം മനസ്സിലാകുന്നില്ലല്ലേ? Oral it is used for amoebiasis, intestinal amoebiasis. But parenterally it is used for ശരിയാണ്. ഏതാണ്? visceral leishmaniasis. Kanamycin, amikacin, cobra. Cobra is classically developed to combat. Cobramycin is classically used to combat pseudomonas. അതിന് വേണ്ടി മാത്രമാണ് ഉണ്ടാക്കിയിരിക്കുന്നത്. Gentamicin, Sisomycin, Nifimycin are the others. Streptomycin also be a different group. Just a minute. Also we'll discuss. Yes, amyloid glycoside. First, let us look at the features of amyloid glycoside. After when you are coming, can you bring one strip of gentamicin? You want money? One choro. Genda കിട്ടില്ല, വേറെ ആയാലും കുഴപ്പമില്ല. അമിക്കാസ് ആയാലും കുഴപ്പമില്ല. അതാ ഉറപ്പാണോ? വൈകി കോട്ടൺ അമോണിയം കോമ്പൗണ്ട് നിയോസ്റ്റിഗ്മീനാണ്. They are highly ionized compounds. ഈ highly ionized compounds പ്രശ്നം എന്താണ്? ഈ ionized drugs in the പ്രശ്നം, because of the ionization are the water molecules absorbing. Very ചുറ്റി water molecules join ചെയ്യും. Clear? They are highly ionized. As a result, surrounding water molecules will come and attach, and they become polar. When they become polar, the drug cannot go through the cell membrane, is not absorbed. അതുകൊണ്ട് what do we do? We have to use them parenterally. ആണല്ലോ? parenterally കൊടുക്കുമ്പോൾ IV ആയിട്ട് കൊടുക്കുന്നു വെച്ചോ. Where does it remain? In the intravascular volume. Because it is highly ionized, it does not penetrate into the cell. ശരിയല്ലേ? Tissues it does not penetrate. So volume of distribution is low or high? Low. How much it goes to tissues? Volume distribution. Volume of tissues low. It remains in the blood. Clear? Next. Because it remains in the blood, volume of distribution is low, it can be easily removed by hemodialysis. Next. At the blood il kidakunadu. Yes or no? Very high concentration achieved in the blood. Naturally, it is very effective in gram-negative septicemia. Next, removed by hemodialysis. In metabolism, what is necessary in our body? To make lipid soluble substances fat soluble. Oh, water soluble or polar. Seriously, so that it is easily excreted by the kidney. It is already polar ആണ്. Does not need biotransformation. Really? Excreted as such into the urine. Yes or no? That is the reason why it is very effective in UTI. It is classically cleared by glomerular filtration. By glomerular filtration. While penicillin is tubular secretion. Have you taken down? Next, spectrum. Look at the spectrum. Only gram-negative aerobic bacilli, some activity against gram-positive cocci. You are not writing down? No, very good. How are you going to recollect? You can get my notes in black market. Kottayam, Lucknow, Bihar attended. Because I basically want you to use one of your cells more, one more cell so that it registers with your hard disk. There is one very sadist person. You are trying in a look at my university is so swollen up. Apparently, two sandosham. One, go home, take a tablet of ibuprofen. MCQ, safest NSAID. Ibuprofen and naproxen. MCQ. 2. Unlike indomethacin, ibuprofen, what the problem? Peripheral swelling point. Hello? Peripheral swelling, gastritis. Peripheral swelling is gone. So, you have central swelling will die. Ibuprofen does not affect that. Why? That's the next MCQ. Because unlike indomethacin, ibuprofen does not cross the blood-brain barrier. So, AVR matrame, you will retain. It can be like one boy in 2008 who never wrote any note in Trichur. Abruta CM friendly irundu Vijay pole friendly irundu only redilla. So after 1 hour I asked that boy, how are you going to recollect? How are you going to recollect all those things? Sir, no problem. Can you go to Will Joseph and Harrison, Goodman and Vaikambatilla? All those things are concise and given to you. How are you going to recollect? Sir, no problem, I will recollect. Tamil Nadu. I said, how? Not those who are taught you will be able to understand what you have written. Now, how are you going to recollect? Sir, no problem, I will recollect. The reason was I was going very fast and he was looking at me. When I was trying to look at the teacher, no teacher, I know no. Well, others are not at all getting any effect of the class. Fast at going in. He was not writing any note. So I asked, how? Sir, no problem, sir. I said, how? Sir, my wife is writing down for me. Walk body the point. Alright? Ultimately, he got the second rank in PGI. Body connectivity in Kerala. So, always have a habit of writing down. Otherwise, you will not collect. Is that clear? Staphylococcal, enterococcal is always combined with penicillins. Aminoglycosides will take why? Yes, your friend is writing down for you. He is writing down for you. Yes. Yes. So, it is always combined with beta-lactam antibiotics. Why? Why? Within 2 days, resistance will. Aminoglycoside inactivated enzymes. Within 2 days, immediately develop resistance. not at all effect in anaerobes, gram-negative cocci and gram-positive bacilli. Very clear? Very clear? Antibacterial activity is very high in alkaline media. Can you give me the MCQ behind that concept? Clue. ഞാൻ ക്ലൂ തന്നില്ലല്ലോ. എനിക്ക് ഉത്തരം പറയണം. INH. Pyrazinamide. Rifampicin. Streptomycin is not effective against intracellular or extracellular pathogen. Extracellular pathogen, that's all. Extra limit intracellular. Which I agree. Yes, why? Why did you say that? Intracellular pathogen, that is in the macrophages, correct? Correct? Inside the macrophages, the medium is acidic, where aminoglycosides are not effective. Got the answer? None of them has anaerobic activity. Ototoxicity, nephrotoxicity, neuromuscular blockade. Tell me which is reversible, which is irreversible. Why? Why? അതറിഞ്ഞൂടാ. എന്ത്? So, what are the nephrones? The maximum toxicity aminoglycosides do to the kidney is to proximal tubular cells. Clearly? Yes or no? And proximal tubular cells has the ability to regenerate, while the hair cells do not have the ability to regenerate. So, cochlear toxicity or ototoxicity is irreversible, nephrotoxicity is reversible. Neuromuscular blockade, reversible, irreversible. Irreversible. In neuromuscular blockade, എന്തുകൊണ്ട് ഉണ്ടാവുന്നു? മനസ്സിലായോ? പ്രോബ്ലം മനസ്സിലായോ? എന്താ പ്രോബ്ലം? ചുമ്മാ പഠിക്കാൻ ഓരോന്നിനും ഓരോ കാരണമുണ്ട്. ഇതാ ക്ലിയർ? പ്രീ സിനാപ്റ്റിക് ന്യൂറോണിൽ നിന്ന് അസറ്റൈൽ കൊലിൻ when it is released, neuromuscular junction, correct? Neuromuscular junction, the NM receptors are there. Yes or no? Acetyl choline will go and act on the NM receptor. Yes or no? അങ്ങനെ contraction ഉള്ളത്. So what is the neurotransmitter released? Acetylcholine. Only when calcium ion come inside, acetylcholine will be released. The calcium mediated exocytosis of acetylcholine is blocked by aminoglycoside. It blocks calcium mediated exocytosis. Why aminoglycosides are not effective against anaerobes? Tell me. See, yes. Now, gram-negative bacteria, anaerobes, there is pouring channel, correct? It can go easily. But what is the main problem? aminoglycosides mainly act inside, protein synthesis, yes or no? For that aminoglycosides, so have a serious somewhere. You studied there. ഞാൻ എനിക്കെന്ത് ചോദിച്ചില്ല, കോട്ടയത്ത് സ്റ്റുഡൻസ് ആരുണ്ടോന്ന് ചോദിച്ചില്ലായിരുന്നു. ഞാൻ ചോദിച്ചിരുന്നില്ലേ? അല്ല, നമ്മൾ ഇല്ലായിരുന്നോ? കൈ പൊക്കി, പക്ഷെ സാർ കണ്ടില്ല. ഓട്ടോറിക്ഷ ഇങ്ങനെ, അതല്ലെങ്കിൽ ഇങ്ങനെ കാണിക്കും. അതേപോലെ സർ, ഐ ആം വെരി ഫെമിലിയർ വിത്ത് ദിസ് ഫേസ്. ഞാൻ പഠിപ്പിച്ചുകൊണ്ടെന്ന് എനിക്ക് ഉറപ്പുണ്ട്. aminoglycoside. But the entry, for it to inhibit protein synthesis, it has to go through the cell membrane. But the entry of aminoglycosides through the cell membrane is oxygen dependent, which is not seen in anaerobes. Water oxide or liquid oxide, which is irreversible? It concentrates in pendulum endolin, alters the iron concentration, damages hair cell irreversibly. ഈ ഹെയർ സെൽസ് എല്ലാം കൂടെ ഫ്യൂസ് ആവും, ജൈന്റ് ഹെയർ സെൽ ആവും. പിന്നെ തിരിച്ചൊരിക്കലും ഫംഗ്ഷൻ റീറ്റെയിൻ ചെയ്യില്ല. ഈ alters iron conservation was the previous question for Andhra entrance they asked. Iron concentration alter ചെയ്യുമ്പോഴാണ് ഇൻഫ്യൂസ് ചെയ്യുന്നത്. Both cochlear and vestibular toxicity takes place. Cochlear toxicity കിട്ടി കഴിഞ്ഞാൽ പിന്നെ hearing is gone. But vestibular toxicity balances somehow. Partly it can be balanced. Odor oxide is increased by vancomycin, furosemide, ethacrylic acid, erythromycin, cisplatin. Previous PGI question for you. ഇതിനകത്ത് ഒരെണ്ണം മലയാളില്ലേ? ഉറപ്പാണ്. ഇതിനകത്ത് ഒരെണ്ണം is produces reversible deafness. That was a PGI question for you. Yes? ഒരു ക്ലൂ തരാം. അതിലൊരു പ്രോ കൈനറ്റിക് ആക്ടിവിറ്റി കൂടെ അത് നിമിഷിക്കും. പിന്നെ കൂടെ പരീക്ഷ രണ്ടുപേർക്ക് ഒത്തു ഹോൾ ടിക്കറ്റ് തരും. രണ്ടുപേരുടെ പേര് കൂടെ ചേർത്ത് ഒത്തു ഹോൾ ടിക്കറ്റ് തരും. erythromycin. It also increases activity of motilin receptors. ഒരു ക്വസ്റ്റ്യൻ ഉണ്ടായിരുന്നു. ക്വസ്റ്റ്യൻ മോഹൻ റഷീദ് ഒരു പേഷ്യന്റ് ഓർത്തോണം ചോദ്യം. ഒരു പേഷ്യന്റ് ഈസ് അഡ്മിറ്റഡ്, ഒരു ചൈൽഡ് 6 years old ഈസ് അഡ്മിറ്റഡ് വിത്ത് ഫീവർ, വോമിറ്റിംഗ്, jaundice, sign hepatitis, enlarged, liver enlarged. He had a history of antibiotics for 1 week. The most likely antibiotic he has been taken: amikacin, erythromycin, clarithromycin, azithromycin. Mindes. മോട്ടീവ് റിസപ്റ്റർ സ്റ്റിമുലേറ്റ് ചെയ്യുമ്പോൾ ലിവറിൽ ജോണ്ടിസ് അടിക്കുമോ? അത് ഏത് ഒപ്പിട്ടതാ? നമുക്ക് സെൻഡ് ടു NJ ന്യൂ ഇംഗ്ലണ്ട് ജേർണൽ ഓഫ് മെഡിസിൻ അയക്കാം. ന്യൂ ഒരു കൺസെപ്റ്റ് ചെമ്മിക്ക് correct. It is notorious for producing cholestatic jaundice. Erythromycin acetylate. പക്ഷെ all erythromycin is responsible. Mohammed Rashid, ഞാൻ എന്റെ കളിയാക്കുന്നത് don't take it seriously. Okay? See, the problem is whenever you call by a name, no? ഇന്നിപ്പോ മുഹമ്മദ് റഷീദിന്റെ പ്രശ്നം എന്ന് പറയാം. This usually occurs when you call by a name, he is always tense. Maybe fraction of second പോലും he can't divert his attention. എപ്പോ അടുത്ത ചോദ്യം വരുന്ന അറിഞ്ഞൂടാ. He will always concentrate. Yes. The answer is erythromycin. Aminoglycosides concentrates in renal cortex. ആണല്ലോ. And produces proximal tubular cell toxicity. ആണല്ലോ. If you have a aminoglycoside which concentrates less in the renal cortex, naturally it will be having the least nephrotoxicity. സമ്മതിച്ചു. Yes. അപ്പോൾ among the aminoglycosides nephrotoxicity കുറവായിരിക്കും. For one, because it produces less concentration in the renal cortex. Which one? അറിയാമോ? അറിഞ്ഞൂടെ? അറിയില്ല. Streptomycin. Yes, the nephrotoxicity is increased by 1, vancomycin, 2, amphotericin B. Amphotericin B is notorious for nephrotoxicity. Polymyxin B, cisplatin, cyclosporine. എപ്പോഴും ഡോസ് ഡിപ്പെൻഡന്റ് ഓഫ് സൈക്ലോസ്പോറിൻ ചോദിച്ചാൽ ഈ പോളിപെപ്റ്റൈഡ്സിനൊക്കെ ഒരു പെക്യുലാരിറ്റി ഉണ്ട്. പോളിപെപ്റ്റൈഡ്സിന് 2 അഡ്വാൻറ്റേജ്, 2 യൂസ് ഉണ്ട്. 3 MCQs ഉണ്ട് പോളിപെപ്റ്റൈഡ്സ്. പോളിപെപ്റ്റൈഡ്സിന് ഹെറ്ററോടോക്സിറ്റി കുറവാണ്. 2, പോളിപെപ്റ്റൈഡ്സിന് ബോൺ മാരോ ഡിപ്രഷൻ ഇല്ല. 3, polypeptides most important toxicity is nephrotoxicity, which is their dose limiting toxicity. So if you ask the dose limiting toxicity of cyclosporine, it is, come on, nephrotoxicity. Mohammed Rashid ഒരു ശ്വാസം ശരിക്കും വിളിക്കുകയാണ്. Mohammed Rashid, which is safer? Given once daily or 3 times. For example, 80 milligram 3 നേരം കൊടുക്കുന്നതാണ് safe, or 80 milligram, that is into 3, 240 milligrams once daily. Once daily. എന്തുകൊണ്ട്? ഒരു ആരെയും സഹായിച്ചു. കോൺസെൻട്രേഷൻ ഡിപ്പെൻഡന്റ് സംഭവിച്ചു. അമിനോഗ്ലൈക്കോസൈഡ്സ്, ഫിനലോൺസ്, ഇതിന്റെയൊക്കെ പെക്യുലാരിറ്റി ഇൻക്രീസ് ദ ഡോസ്, കില്ലിംഗ് ഓൾസോ ഇൻക്രീസസ്. 80 മില്ലിഗ്രാം 3 കൊടുത്തത് പോലെ 240 മില്ലിഗ്രാം ഒറ്റ ഡോസ് കൊടുത്താൽ കില്ലിംഗ് ഓൾസോ ഇൻക്രീസസ്. സോ കോൺസെൻട്രേഷൻ ഡിപ്പെൻഡ് കില്ലിംഗ്. ഒറ്റ നേരം കൊടുത്തു കഴിഞ്ഞാൽ ഹൈ കോൺസെൻട്രേഷൻ കൊടുത്താൽ. പക്ഷെ അതല്ല, അത് അഡ്വാൻറ്റേജ് ആണ്. മോസ്റ്റ് ഇമ്പോർട്ടന്റ് അഡ്വാൻറ്റേജ് ആണ്. ഞാൻ ചോദിച്ചത് വിച്ച് ഈസ് സേഫർ എന്നാണ് ചോദിക്കുന്നത്. സേഫർ എന്ന് ഉദ്ദേശിക്കുമ്പോഴത്തേക്കും നെഫ്രോടോക്സിസിറ്റി ആൻഡ് ഓട്ടോടോക്സിറ്റി ആണ്. ശരിയല്ലേ? അത് 3 നേരം കൊടുക്കുന്നതാണ് സേഫ്, അതോ ഒറ്റ നേരം കൊടുക്കുന്നതാണ് സേഫ്? ലോജിക് 3 ടൈംസ് ആണ് അല്ലേ? തെറ്റാണ്. For every aminoglycoside, ഓരോ aminoglycoside there is a particular plasma consolidation, which we call the threshold or trough consolidation. Which we call the threshold or trough consolidation. So, which you know. For example, gentamicin. Gentamicin trough concentration is 2 microgram per ml. Toxicity to the hair cells and toxicity to the nephrons depend upon how much time, again I underline, how much time the hair cells and the nephrons are exposed to aminoglycoside above the threshold concentration. Did you understand the concept? Above the threshold concentration, the hair cells and nephrons are exposed to aminoglycosides, we determine their damage. If I 240 milligram, plasma concentration is high. Yes or no? I don't know. So time concentration dependability. Okay. 2. Okay. After 4 hours, it comes below the threshold. But then 3 times okay. 2, 4, 8, almost 10 to 12 hours, the hair cells and the nephrons are exposed to aminoglycosides above the threshold concentration. So, toxicity is more if it is 3 times daily. What's maximum cochlear toxicity? Maximum cochlear toxicity. Answer. Parnyalu. Amic acid. Nephrotoxicity. Gentamicin. If you are asked, gentamicin, this is gentamicin. Neomycin controlling, and where only that, neomycin. Maximum vestibular toxic. Neomycin is never used parenterally. Are you know? If you are asked, enterococcal endocarditis. Amic acid prefer you, gentamicin prefer you. ഇത് അടുത്ത നമ്പർ. ചോദിക്കുമ്പോൾ ഉടനെ എഴുതാൻ തുടങ്ങും, മൂത്ത് നോക്കില്ല. പിന്നെ കുറച്ച് ചോദ്യം ചോദിക്കുമ്പോൾ കമന്ന് കിടക്കും. ചോദിക്കുന്നത് ഉത്തരം which one? Enterococcal endocarditis. Which one you will use? Amic acid ഉപയോഗിച്ചോ gentamicin ഉപയോഗിച്ചോ along with penicillins? Use your brain. Clue. Long term നമുക്ക് ഉപയോഗിക്കണമെങ്കിൽ nephrotoxin ഉപയോഗിക്കണം. Because nephrotoxicity is answer. Gender ഉപയോഗിച്ച് amic acid ഉപയോഗിക്കണം ചോദിച്ചത്. Gentamicin. Did you understand the concept? So the previous SGPJ question for you. Long term use ഉപയോഗിക്കണമെങ്കിൽ it is gender ഉപയോഗിക്കും. Nephrotoxin use. Maximum vestibular toxicity is streptomycin. Maximum neuromuscular blockade. Which one? That's also streptomycin. Least ototoxic? If you answer, least ototoxic. മറന്നുപോയി. ശരി, ഈ ഓറലിൽ ഇരിക്കുമ്പോഴത്തേക്കും what is the answer? Sir, answer പറയും. Are you sure? Yes sir. Are you sure? No sir. പിന്നെ എന്താണ് ഉത്തരം? സോറി സർ, മറന്നുപോയി. റഷീദ് ഒന്നും പറ്റില്ല. എക്സാമിനേഷനിടയിൽ ആരുമില്ല. റഷീദും ക്വസ്റ്റ്യൻ റഷീദ് ചോദിക്കും അറിയാമോ ഇല്ലയോ. ലീസ്റ്റ് ഓട്ടോടോക്സിക് ഈസ് മെത്തിൽമിസിൻ. ലീസ്റ്റ് നെഫ്രോടോക്സിക് ഈസ് അത് പറഞ്ഞോളൂ. വൈ least concentrated in the cranial cortex. This we have discussed. Tularemia, you can use, see here, one thing, brucellosis. Brucellosis, in your textbook it is given, the gold standard WHO classification, brucellosis, it is rifampicin plus doxycycline. Analo, പക്ഷേ ഹാരിസൺ അമേരിക്കൻ സ്റ്റാൻഡേർഡ്സ് it is doxy plus but Harrison it is rifampicin plus, it is doxycycline plus IM streptomycin. Why? Karanam, Americans പറയുന്ന കാര്യമുണ്ട്. They say that rifampicin is an enzyme inducer. Correct? It will induce the metabolism of doxycycline. Plasma level of doxycycline കുറയും. Brucella may develop resistance. Resistance develop ചെയ്താൽ പിന്നെ ഒരു മരുന്നുമില്ല. Streptomycin plus doxy കൊടുത്താൽ streptomycin does not have any enzyme induction. Correct? Yes or no? Can be safely used. It is IM streptomycin plus oral doxycycline. Plus oral doxycycline. Can break down. Spectinomycin is an amino cyclitol, we have already discussed. This will be used in gonorrhea. I think so you can have your tea break and come back. Sorry, lunch break. ഞാൻ ഒരു തെറ്റ് പറയാനായിട്ട് വിജയ് കാത്തിരിക്കുകയായിരുന്നു.